Dr. R.K. Sharan, Professor Pathology, GB Pant Hospital, New Delhi. Our faculties for the today is Dr. S. Dattagupta, Professor one by one.
Medical College.
Medical College. Dr. Nisha Modi and my kindly leave the meeting and a few disclaimers. 5th September, Laboratory Management including Inventory Management, LIS Costing by Dr. Sujay Prasad Sir, Technical Director, Newburgh Anand Reference Laboratory, Bangalore. And the next, after that is on 7th September, slide seminar on cervical cytology case-based approach by Dr. Hemant Kumar and Dr. Jennifer, CMC Medical College, Vellore. I'll request Dr. Dattagupta Sir to share his screen.
Yeah, able to see now?
Yes, sir. Yes, sir.
Yes, sir. Good evening, everyone. It's been a pleasure and an honor. I thank Dr. Borges and Dr. Sumit Gujral for this opportunity, which we have been cherishing for long. I also thank the chairpersons, none other than Dr. Dalal, who is a very famous pulmonologist from Mumbai, and our dear friend Dr. R.K. Saran, one of the finest pathologists we have, who is in GB Pant Hospital, Delhi. I also welcome the students, and we are going to learn from them today. So we are nervous, both of us. And my colleague, Dr. Sudhir Arava, one of the finest gentlemen and a wonderful histopathologist and dermatopathologist, has actually collected all the cases. So all credit goes to him. So we'll start with these granulomatous inflammation. This is the disclaimer that's meant for teaching purpose, and we've collected data from our own experience with the cases and other things, and we have acknowledged wherever we have taken material from. There's no financial interest or conflict of interest. Now, the way that we'll go about this is that I'll first give a small introduction about granulomas. This is important because you would have learned granulomas as an undergraduate. So as postgraduate, there are certain extra things that you're expected to know. How much it helps you, question that you learn in due course of time, and then we'll come to the cases. It's not possible to cover all aspects of granulomatous inflammation. We'll just give you some examples so that you can work on them as you learn. So first of all, we come to the definition of a granuloma. So basically, it's a collection of mature mononuclear phagocytes. It's called mature because the moment it's immature, you think of neoplastic diseases, and it is not necessarily accompanied by necrosis or other features like this. So where there is no necrosis, some people call it pure granulomas, and where there's necrosis and other features, some people use the term complex granulomas. There are other definitions. It's an inflammatory response, the chronic type, with collections of macrophages, epithelial cells, and multinucleate cells. And so everywhere, what is important is whatever definition you take, it's an organized collection of mononuclear phagocytes, with or without giant cells or necrosis and so on and so forth. So please note that the word epithelioid is often misspelled. After L, there is an O sitting between two I's, and then there is a D. So epithelium, epitheli, then instead of there's OID. So that's one thing you have to remember. End result of granulomas is healing and repair, so you have fibrosis. So now we'll go to the next slide. If you see, the first time granuloma was used was by Rudolf Virchow himself. Most of the things that we are talking about took place in a span of 10 years, between 1863 and 1873. So Virchow used the term granuloma for the first time. He had seen giant cells, but he never mentioned that there were giant cells as such. So he said there are cells with some 50-60 nuclei that you see. But it was Theodore Langhans in 1868, he used the term giant cell. And we know that in tuberculosis, he used the term Langhans giant cell after his name, because at that time he described it in tuberculosis. Wagner described what's called epithelioid cells. Some people say it's Robert Koch and Cornell. They also use this name. But however, the first case of inflammation with epithelioid cells in addition to tuberculosis was described in a fungal joint synovitis by a person called Costa. It was in 1870-73 that Schuppel claimed three obligate cellular elements: giant cells, epithelioid cells, and you can see other things like necrosis. So in these 10 years, this thing happened. So just in case you forget how Virchow looked like and Theodore Langhans looks like, here are the two stalwarts. So the first thing that you have to understand in any granuloma is that important cell is the histiocyte. Now histiocytes generally have two major functions. One is antigen presentation and another is phagocytosis. The antigen presenting cells, the macrophages or histiocytes can present, but the cells that are specially endowed with antigen presentation are the Langhans cells and dermal dendrocytes. The phagocyte is known as a macrophage. Phage means eating up, macro is a little larger cell, so that's why it's called macrophage. And the macrophage has got various functions, including response in wound healing, in addition to phagocytic, cytotoxic, and regulation of inflammation. The disorders of monocytes, histiocytes, and macrophages are divided into three categories. Functional defects, they're mostly hereditary, like in Gaucher's disease, Niemann-Pick, Shadia-Kigashi. One of the other enzymes are not working properly or absent, so you get accumulation of various substances in these. Reactive responses, which are non-neoplastic, and then of course neoplastic, like histiocytic sarcoma, Langerhans cells, histiocytic dendritic cells. Macrophages are generally, so what we are going to talk about today is mainly phagocytic cells and the reactive response. We will not delve upon the functional or the neoplastic diseases. So granulomas are related to phagocytic cells, and they are responsive to certain external noxious stimuli. The macrophage is generally a large cell with a vesicular nucleus, and you can get a small nucleoli. Sometimes you do find certain gobbled up material in them. The Langerhans cells, on the other hand, are more characterized by the nuclei, which may have grooves. I'm sorry, I'll take this laser point, I believe. Yeah, they have these grooves, and the nuclei are irregular. Actually, they're folded, and that's why you have this grooved appearance. Dendritic cells, on the other hand, they're found especially in the lymph nodes. They often occur in pairs. They are more vacuolated than the centroblasts or the surrounding cells, right? And they have a small nuclei in them. So this is how the dendritic cells look like. So we are talking about these cells, not about this or this. Okay? So the macrophage, you have to know, they are embryonic in origin. They come from the bone marrow, hematopoietic stem cells, and they invariably get located in various organs in the body. Now these macrophages which come directly from the embryonic stem cells, they are long, they live for a long time and they can renew themselves. On the other hand, these organs also have monocytes which are circulating in the circulation, and whenever required, they enter into the tissues. These monocytes are short-lived and they come on demand. So you have two types of cells, the monocytes from the bloodstream and from the bone marrow directly in prenatal life. These cells generally go by certain names. Like for example, in the lung, they are alveolar macrophages. In the liver, they are Kupffer cells. In the brain, they are microglial cells. In the brain, especially, this is important because the blood-brain barrier opens for a short period in the prenatal period, and all these cells populate them. The leptomeningeal cells are essentially those which have come from the bone marrow. Very rarely, your brain opens up to welcome the other monocytes. Then, of course, in the intestine, skin, and kidneys, you have them. Now, this is very important to note. Okay. Then we'll come to the different types. So you have the embryonic derived macrophages. They're mainly tissue specific. They go into the bone as osteoclasts, microglial cells, alveolar macrophage, Kupffer cells, histiocytes, white pulp, red pulp, littoral cells, and so on and so forth. But in addition, when there's a whole lot of trafficking of movement, especially from the peripheral blood cells, where you have the inflammatory monocyte. These are short-lived, these are long-lived, but they have essentially similar function. So different tissues have different things. For example, the CNS and the epidermis, mainly the Langerhans cells, they are all the original from the bone marrow. Whereas in the intestine and the dermis, the majority are from the monocytes that come from the bloodstream. The remaining have a mixture of both of them. But when these are depleted, that is in the case of inflammation and so on, the monocytes jump into the scene and they populate those organs whenever required. These macrophages.
Can I explain this, sir?
Yeah.
So there are some of the attendees calling that it's a very soft voice. Can you be a little louder, sir?
Yeah, now can they hear me?
Can you make the volume full? It is still not.
Yeah, full,
perfect.
full, full.
Thank you, sir.
Okay. Okay. Now, macrophages have got a variety of receptors. So, you know, they are one cell with perhaps one of the maximum number of receptors, so they have a variety of functions. Not going to this. But what you have to know is an activated macrophage is generally of two types, M1 and M2. The M1 is the classically activated ones by bacteria, by other organisms. They are pro-inflammatory. They result in a Th1 or cell-mediated response, and they function for host defense and anti-tumor immunity. M2 are alternatively activated by cytokines, and they regulate wound healing. The second part of the story. The first part is fighting the organisms. Second part is when that is done, tissue repair sets in, and M2 macrophages are actually for that. Now, M1 macrophages, you can do CD80 or INOS to identify them. M2, you can do CD163 or 206, 209 to identify them. Now, the importance of these two will come later. Morphologically, it's very difficult to distinguish two. Now, how do the macrophages become M1 or M2? All macrophages have got arginine. So, if they activate the INOS pathway, they produce nitric oxide and they become M1 macrophages, which inhibit cell proliferation. They gobble up bacteria and so on and so forth. Suppose they activate the arginase pathway, then from they produce ornithine and urea. They become M2 macrophages, and this helps in cell proliferation and repair. So you see, there are two types, M1 and M2 macrophages, depending on their function. So you have to understand what is good is M1 macrophages can therefore become M2, M2 can become M1 whenever required. So there's a good admixture of these two types of macrophages, and the cells can go from one to another. Okay, so the macrophages have got a function which is called SHIP. What is sampling? They either sample the bacteria or the area that has to be healed. Okay, they heal or inhibit bacteria, and then they present antigen. They're not very good at presenting antigen, but never mind. M2 is for Th2 or antibody, they present to B cells. M1 is for Th1 or cytotoxic, and they present to cytotoxic T cells. So you see, these macrophages do a lot of function that way. Now, how do you distinguish? Morphologically, is there difference? Well, in cell culture and all, they say the M2 are larger cells than M1. Okay, and it's very difficult to make out in tissue unless you do an immunohistochemistry. Now, in an infection, will you get M1 or M2 exclusively? No, you generally get a mixture. For example, this is in a cholesteatoma, and you find in this cholesteatoma it's in the healing phase. Although there are M1, which is identified by CD80, and M2 by CD163, there's a admixture of M1 and M2. There's a preponderance of M2 because it's in the healing phase. Right? Now, this is in a non-necrotic and a necrotic granuloma, and this is in a non-granulomatous tissue. So this is the stain for macrophages in general, CD68. This is INOS, and this is CD206. So you see, you can get a mixture of both of them depending on when it is required. Now here we come, the macrophages, if they are unable to tackle the bacteria or the foreign material, they generally become more active and become what are called epithelioid cells. Epithelioid cells are so called because they form almost a syncytium. One cell joins another. There's almost a tight junction between all these macrophages, as if they formed an epithelium. How are they identified? They have a eosinophilic cytoplasm. They almost join each other, and they have a nucleus which is slightly elongated or irregular. And classically, they're supposed to be shaped like a slipper. This is the sole, this is the toe end, and therefore, in undergraduates, we say that they are slipper-like nuclei. But it's not necessary that you'll always find slippers. So you can find them round, they can find them oval, and you have a dot-like nuclei in them. Okay. Please remember, the term epithelioid is used to indicate epithelial-like morphology. Various tumors are called epithelioid tumors, but they are not similar to the epithelioid cells in granulomas, which are essentially macrophages. For example, in picomas, epithelioid cells are not macrophages. They have origin from melanocytes and smooth muscle cells. Epithelioid discs are gist cells only. They are interstitial cells of Cajal. Epithelioid leiomyosarcomas are smooth muscle cells. So you can have a variety of epithelioid. The term epithelioid used to prefix tumors. Don't mistake them for epithelioid cells of the granulomas. Right? So how are they different from usual macrophages? They have a lot more lysozymes. compared to the usual macrophages. They have interdigitating surfaces that lock with the surrounding ones, and they also have these cup-like depressions in the edges of most of these cells. So these are the features by which you identify epithelial cells. They are rich in E-cadherin, that's why they join with each other, can do a stain. They also have placoglobulin and other things. Sometimes they also have actin in them. So you see, this is how they become a tight granuloma or organized to form all these cells. So this is what you see in a granuloma. Now a granuloma is like the foyer of a medical college. A whole lot of people going in and going out. So it's not only just epithelioid cells with necrosis and the organism. You can have T cells, B cells, NK cells, neutrophils, mast cells, and even blood vessels. Whole lot of cells in that. One thing is, some studies have shown that the center of the granulomas, if it is necrotic, obviously have M1 cells more than. M1 are pro-inflammatory. They are more phagocytic. They secrete nitric oxide. So they are more killing in that way. M2 are in the periphery. They are more involved with healing, fibrosis, and repair, and that is why in the periphery of granulomas you get fibrosis, central area necrosis. The M2 are more E-cadherin positive than M1. So you see, you have a non-epithelioid granuloma, then you have epithelioid, then they become necrotic if there is uncontrolled infection, the right amount of TNF is not there, then they become necrotic. On the other hand, if they have IL-13, TGF beta 1, then they become more towards the M2 and they become fibrosis. Some granulomas will have more of giant cells than the epithelioid cells, right? So we'll come to that. So what are these giant cells? The giant cells are generally because of homotypic cell fusion. Homotypic means similar cells fusing with each other. Now I'll ask you a question. Can you give an example of heterotypic cell fusion? Divyanshu, just give them 10 seconds. Give an example of heterotypic cell fusion. Two different cells fusing together. Any response?
No, sir, not yet.
No response.
Oh, you must go for it, asking for this egg cell and the sperm cells. Anyone?
Yes.
Is one.
That's the way.
Yes, you are absolutely right. The best example is spermatozoa and ova fusing together to form the embryo. Yeah.
Someone has written it on it.
Yeah, very good. So the giant cells are because of macrophages fusing with each other, which is called homotypic. This happens even in tumor cells. What is the size to call a giant cell? There is no definite size, but they are generally large. But some authors say they are usually more than 40 micrometers in size, 40 to 120. They may have one large nuclei or two or more nuclei. Generally, they are two or more nuclei. So you classify them as physiological and pathological. Physiological, you have osteoclast, syncytia trophoblast, and megakaryocytes. Okay. Now, how many nuclei do megakaryocytes have? Just 10 seconds. Any other students who are here today?
That is very simple question. Let us answer.
So actually, there is endomitosis in that. Around 70, sir, 1x to 72 times the nuclear is increased, DNA is increased.
Yeah, actually, megakaryocytes have a single nucleus that is lobated. But the amount of DNA, yes, you're right, because of endomitosis, it can replicate and it can go larger and larger. But unfortunately, in tissue sections, because they are cut across, you find as if they have multiple nuclei. Please remember this when you're doing, when you're looking at megakaryocytes. Don't make the mistake of saying they have multiple nuclei. They may have 64 DNA or 32 copies of the normal complement of DNA in a human cell. Okay, pathological could be inflammatory. Yeah.
Sir, then why it is a fusion? How can we call it a fusion when there is no?
No, it is. You see, that's why it is generally but not limited to. So it's not always due to fusion. It means it's a large cell actually. Okay, so that's why megakaryocyte is an example of it. Now among the inflammatory cells, inflammatory giant cell, you have foreign body, Langerhans cells, Anischkow cells, and Aschoff cells. You have in rheumatic heart disease. Two-tone giant cell in which there is a central cellular area with nuclei, and then you have again cytoplasm in the periphery. In Langerhans cells, they are arranged in the periphery like a horseshoe or all around like a wreath. Foreign body, they are just scattered all over. What is this type of cell called? Anybody? As an undergraduate, we expect 1, 2, and 3. And if they can tell this also, very good. So now you tell this extra one. Anybody? Okay.
So few replies are there. Osteoclastic and crouton cell.
Very good. This is called a crouton giant cell. Crouton giant cell is a giant cell with a lot of cryptococci in them. So cryptococci looking like crouton giant cell because the nucleus are in the center. They are called crouton giants. Anyway, croutons are nothing but those breadcrumbs that they put on top of soup and other things, small pieces of bread that are fried. Okay, this is a crouton giant cell. Yeah. So pathological viral infection, you have herpes, cytomegalo, Warthin-Fingaldi, and respiratory syncytial virus. So these are the giant cells seen in viral infection. In tumors, osteoclastoma, Reed-Sternberg cell, anaplastic tumor giant cell. They may have just one nucleus, which is very large. The cell is large, and of course, they have irregular nucleoli and so on and so forth. And you can have a rhabdomyoblast. Then there are others, neonatal giant cell hepatitis, a large hepatocyte with 3 or more nuclei, and a muscle giant cell. So you see, this is the list of the various types of giant cells that you see. If anybody asks you as a postgraduate, at least try to tell some of them and classify like this, you'll be able to remember most of them, right? So this is a crouton giant cell which has got this nuclei here. These are all cryptococci, right? And it's seen in cryptococcus. Okay, so you do a stain, you'll find PA stain is enough. What are titan cells? Anybody can tell? Okay. Anyone? Okay, Divyanshu.
Yes, sir.
Nobody has said no?
No.
Okay. Titan cells are large cryptococci, more than 15 microns in size. More usual cryptococci are 2 to 4 microns. So these large cells, it's very important. If you see them in tissue section, you please tell they have a thick capsule. The importance is they're seen in the lungs. They are more pathogenic. They cause dissemination and they're resistant to the usual antifungal treatment. Okay. The other things that you must remember in giant cells are inclusions. This is an asteroid body. Schaumann body are calcified. then oxalate crystals you can get, cholesterol crystals, and Hamasaki-Wiesenberg bodies, which can stain like almost like yeast with a silver stain, but they're not that. They're mainly lipofuscin and other material. All this can be seen in sarcoid, right? But they're not specific. You can see these in tuberculosis also. You can see in fungal infections. But anyway, they're helpful in the diagnosis of sarcoid. Can anybody say who this is? No one.
No reply, sir.
He is shaman. Just in case you haven't seen him earlier. Okay, he is a Swedish dermatologist, and he described the shaman bodies in sarcoidosis. Now, so you have these macrophages. They become giant cells. If MTS and rankle is there, they become osteoclasts. If IL-6 and interferon gamma is there, they become foam cells and two-tone cells. If interferon gamma and IL-3 is there, they become Langerhans giant cells. If IL-4 and IL-13 is there, they become foreign body giant cells. So this is how the different giant cells are formed. Okay, so depending on the cytokine that is available, the cells become like that. So certain terms in granuloma, histiocytic aggregates are loose aggregates of histiocytes. Ill-defined granulomas are the small cells loosely arranged. This is an ill-defined granuloma composed predominantly of giant cells. This is an ill-defined granuloma in the liver. It looks like a granuloma, but not so well defined. These are well-defined granulomas. If the cells are a little separated out, they are called loose granulomas. If they are compact, they are called compact granulomas, typical of sarcoidosis. Right? Focal granulomas are granulomas located separately in small areas. This is in sarcoidosis where they are perilymphangious, like and bronchocentric. Okay, so this is focal granuloma in tuberculosis. Diffuse granuloma is where they are not well defined. Classical is lepromatous leprosy. So you have focal granulomas, diffuse, compact, and loose. Compact granulomas without necrosis are called hard granulomas. In the case of tuberculosis, with necrosis, they are called. Sorry, there's something somebody wants. Hard granulomas, they are called. I'm sorry, I'm supposed to do something.
It's not moving.
Yeah, because somebody has asked to share or something like that. Okay, so hard granulomas, and if they are necrotic, they're called soft granulomas in tuberculosis. This is a necrotizing granuloma, this is a non-necrotizing granuloma. Non-immunological granulomas are those which do not have lymphocytic cuffing. Immunological granulomas have a lymphocytic cuffing. So these are the different terms that are used. Discrete granulomas are granulomas separated from each other. They are single giant cell systems. You have epithelioid cell and maybe one giant cell. Confluent granulomas are granulomas which join with each other with multiple giant cells. So this is typical of sarcoidosis. Confluent granulomas are typical of tuberculosis. Spindle cell granulomas. Macrophages which become spindle cells and in the form of a granuloma or spindle cell granulomas. Typical is histioid leprosy. Right? What are these granulomas? Anybody can say? Anyone?
So donor granuloma.
They are called donor granulomas, but the correct name is fibrin ring
Fibrin ring.
granulomas. This is a fibrin ring. Okay, this is a Martial scarlet blue stain, and this is just a PA stain. You have a fat in the middle, epithelioid cells all around them, and the middle of the epithelioid cells you have some fibrinous material. Okay, these are fibrin ring granulomas, typically seen in Coxiella burnetii or Q fever, but you can get them in hepatitis A, CMV, EBV, reaction to certain checkpoint inhibitor therapy, especially seen in the liver, bone marrow. What is this granuloma? Fat with these cells. This is called an oleogranuloma or fat granuloma, typically seen in NASH. Okay, xanthogranuloma, and this is xanthogranulomatous inflammation. There is a difference between the two. This is not a reactive process, just a juvenile xanthogranuloma. It's called a xanthogranuloma, but it's mainly a neoplastic process. Whereas this xanthogranulomatous inflammation seen in urinary tract, ovaries, and gallbladder typically is the granulomatous inflammation we are talking about. They have foamy macrophages, giant cells, and cholesterol cliffs. This is a bile granuloma. So bile granulomas are nothing but encrustated bile with a granulomatous response seen in biliary obstruction. So you can have in the liver ill-defined portal granulomas, bile duct centric granulomas, and zone 3 granulomas. So bile duct centric and bile granulomas are seen in biliary obstruction and PBCs. So you have different types of granulomas, much more than just necrotizing and non-necrotizing. Fibrin ring, you had the oleogranulomas, spindle cell granulomas, and bile granulomas. Okay. Now they are named as granulomatous disease, but they are not conventional granulomas. Like for example, giant cell reparative granuloma is a benign reactive process where you get a lot of osteoclast giant cells and macrophages, but they are not included under granulomatous inflammation. Plasma cell granuloma is a benign lesion composed of mainly plasma cells and some histiocytes seen in the oral cavity, tongue, and gingiva. It's called a plasma cell granuloma, but it is not the granuloma we are talking of today. Okay, chronic granulomatous disease, that is CGD. It is because of NADPH oxidase complex. There's a problem there, and therefore they cannot generate superoxides. And there is a granulomatous inflammation. The neutrophils do not work, the macrophages do not work, so they convert to granulomas, the macrophages, and you get widespread granulomatous inflammation. But this is not included in the inflammatory granulomas and other granulomas we're talking of today. So non-necrotizing granulomas, there is a whole list from A to Z, starting from atypical tuberculosis to zirconium exposure. For there is an easy way, think of RBCs and LDH, foreign body reaction, berylliosis, Crohn's disease, sarcoidosis, typical sarcoid type granuloma, leprosy, drug reaction, hypersensitivity, pneumonitis. These are the common types, and in some countries you can add toxoplasmosis. RBCs, yes, and LDH. Okay. For necrotizing, you have caseating, coagulative necrosis, fibrin necrosis, and different types of necrosis. They are mainly either because of infections due to bacteria, parasites, viruses, or because of immunological mechanisms or vasculitis. These are the two major causes of necrotizing granuloma. So you have non-necrotizing, necrotizing, focal necrosis, suppurative, and so on and so forth. We'll come to each one of them. Please remember, necrotizing is either because of an infection or because of autoimmune or vasculitic process. These are the two major causes of necrotizing granuloma. In cancers, you can get granulomas, one as a reaction to the cancerous material. Classical example is to keratin. Then granulomas associated with cancers, like in renal cell carcinoma, you can get granulomas sitting in the middle of the cancer. Granulomas, even in breast, you can get. Granulomas in lymph nodes, you can get either with metastasis or without metastasis. Without metastasis, it's supposed to confer good prognosis. All these granulomas are generally non-necrotic. The location of granulomas is important for diagnosis. For example, in the lung, if you get necrotizing, it's always an infection. Tuberculosis in our country, in addition, it may be other fungi. Lymphangiocentric or next to bronchial markings, if they are there, likely to be sarcoid. Perivascular, majority giant cells with some talc-like material. Think of talc granules. If it is in the vessel wall, it's a granulomatous vasculitis. Within the alveolar, it may be intra-alveolar loose granulomas. Within the interstitium, if it is in the peribronchial area, expanding and closing the lumen, and if it's peribronchial, which is loose, you have different etiologies. So it could be tuberculosis fungal. If it is lymphangiocentric sarcoid berylliosis, if it is perivascular, non-polarizable sarcoid or berylliosis, polarizable talc, granulomatous vasculitis, autoimmune or systemic vasculitis. If it is within the alveoli, think of cobalt. In the interstitium, tight granulomas. In addition to sarcoid, you could think of hot tub lung disease because of MAC or avium intracellulare. If it is pushing into the lumen granulomas, hypersensitivity pneumonitis, it is loose, not pushing, Begasosis. But these are not typically seen in all of these cases. You may see a case of sarcoid without these typical findings. Please remember that. You have to use the clinical, radiological, and other findings available with you. Okay. In fact, there are various algorithms in which you can do these, look at these granulomas. So we come to the first case, case 1. Kiran, can you just take it up, please? A slide for diagnosis. What did you see?
So it's a section from fibroproteinous tissue.
Mm.
Shows a collection of multinuclear gain cells.
Mm.
Rimmed by lymphocytes.
Okay.
In the center shows foreign body.
Okay.
So probably maybe that granuloma.
Can others mute, please? Okay, please.
Sir?
There's some sound coming. Okay, disturb. Okay. Yeah. Good. And this is polarizable material.
Yes, sir.
Okay. So what is that foreign body?
Foreign body. Yeah.
Okay.
Probably talc.
Okay. Okay. You know, in this granuloma, the most characteristic feature is almost entirely made up of giant cells. They are of the foreign body type. They're not Langerhans type. Number one. Whenever you see a granuloma full of giant cells, mainly of the foreign body type, search for a foreign body. It is unlikely to be infective because if it is infective, you would have found epithelioid and other cells. Secondly, you'll notice there's hardly, the lymphocytic infiltration is sparse. So it's a relatively non-immunological type of granuloma, not much. And then, of course, you're finding the foreign body. Now, in the foreign body, Kiran, you're finding most of them are rounded.
Sir.
If they are rounded and they're almost similar to each other, almost similar, some are cut across, it is very unlikely to be talc.
Okay, sir.
This talc does not look like this. So you see, this is a suture granuloma.
Okay.
Okay. So now you see sutures, if they are like this, you see two things you have to see in sutures. See, talc is like this. Okay. They're irregular. Now the sutures you'll find nowadays most of the sutures are rounded, almost similar to each other. These are called monofilament sutures. They're either vicryl or Proglain sutures. Okay. So these are the common sutures. Both of them you can polarize and you can find them. There are other foreign bodies that you can get. You can get gel foam, PVS sponge. These wide openings are the ones you get in mesh, polyester or polypropylene, or sometimes you get silicone dressing. Chrome gut you get rarely, silk you will get, they're dark in color and they also polarize. Cotton you don't see. Can anybody tell what is this lesion? You're finding giant cells, little inflammation, and this hyaline-like material. You often get them. Anyone? Collagen, okay. See, when you find a lesion like this, you search and search, you will invariably find vegetable matter, serious red stain. This is called, this is called, I think Bindu has said, pulse or hyaline granuloma. The word pulse is meant for legumes or pulses. So vegetable granulomas are called pulse or hyaline granuloma. You see them because of this hyaline-like material in them. So remember, always search for this. Sometimes you will not get this always. You can get tattoo granulomas where you get all this. Okay. And what is this? Anybody? This is a granuloma, foreign body type, hardly any cell, no lymphocytes, and you're finding this bluish gray material. Anybody?
Some needle-like crystals are there. And
Gout.
then
This is polarized. This is if you use the red interference at the back. This is how it looks. Yeah, many people have said Piyush and some other people have said that. Yeah, this is gout, urate crystals. Right? So this is gout. Okay, good. So now we come to case 2. Agam, can you take this?
Yes, sir.
Or let's tell one of the ladies. Rashmi, take it. Rashmi, take it. That's it.
Case 2.
Okay.
18-year-old boy presented with cervical lymphadenopathy. Lymph node excision done for histopathological examination.
Yeah, what I see.
Section shows lymph node tissue with multiple necrotizing granulomas.
Okay.
So in this cover, we can see the necrotizing granulomas with composed of epithelioid histiocytes, some giant cells
Okay.
surrounded by lymphocytes.
Anything else here?
Langerhans type of giant cells are seen.
Anything else? Rashmi? Important thing is they are becoming confluent. See? This granuloma is joining with that. And that's an important finding. Necrotizing with confluent. Yeah, okay. Yeah. Very good. Anything else, Rashmi? You want to add? Rashmi? Can you hear me?
Yes, sir.
Yeah. Anything you want to add further?
about central part.
Anything else you want to add?
Caseous necrosis.
Caseous necrosis. Okay. Anything else? What has happened here? Here you're not seeing anything, no?
Yes, sir.
Most probably it has liquefied here. You can get liquefaction. Okay. What is this cell? This is a typical Langerhans cell. Okay.
Also.
And what you're finding here? This is also granulomas, but it's looking slightly bluish because there may be some inflammatory cells. And this is the same thing going on. Okay. So what is your diagnosis? Most likely?
Tuberculous lymphadenitis.
Any differential?
It could be caused because of the fungal infection also.
Etiology is tuberculosis. Anything you'd like to do?
Yeah, Zielinson staining for the acid fast bacilli.
Okay, so you think it's tuberculosis. It is negative. So what do you think it is? Anything, Rashmi?
Gene expert.
Yeah, PCR can be done too.
Okay. Anyway, in our country, no, we don't have to do the other things. Usually, it's considered as tuberculosis, and I'm sure with the clinical findings and all, in most places, if they can do the other test, well and good. If they don't, sometimes they treat empirically for tuberculosis. Now, this is a reticulin stain. What does it show?
We have very high incidence of drug-resistant TB, so gene expert should be done in all
Yeah,
cases also
yeah.
to confirm and also to rule out drug resistance.
Very good.
5%.
Yes. Ma'am, we'll give you the cases now. So this is the reticulin stain. In sarcoidosis, no, usually it is reticulin rich. Whereas in tuberculosis, because of necrosis and destruction, it is reticulin poor. In sarcoidosis, it is usually reticulin rich, because there's fibrosis. All this immunostaining doesn't help. You can get CD4, CD8 and so on. This is to show you all our macrophages. So necrotizing granulomas, you have different types. I told you once again, remember there are two main etiologies. The necrosis can be rounded or defined, irregular, somewhat stellate. It could be geographic, and it could be basophilic with fibrinoid material, geographic with eosinophilic areas, could be palisaded, could be stellate but uniformly eosinophilic. So now, does the shape help you? It does. This is, for example, this is seen in tuberculosis, this is seen in atypical mycobacteria, or you could get in cat scratch. These you'll find bluish in them, right? It could be seen in cat scratch disease, mainly stellate with basophilic areas because they're neutrophils. Okay. This typically, if you get fibrinoid with geographic areas and blue, think of vagus. If it is like this, eosinophilic and geographic, think of sarcoid, which is necrotizing but is rare. You can get it in tuberculosis. Palisaded, it's mainly rheumatoid diseases. And it's stellate but uniformly eosinophilic. You could get in a variety of conditions. It can also be an infarct in a leiomyoma or some other thing with granulomatous inflammation. So the shape of the necrosis helps you. Then you have caseous necrosis, which is uniformly granular, coagulative, fibrinoid, basophilic, suppurative if there is neutrophils, granular and eosinophilic will be caseous, collagenolitic are more homogeneous, neutrophilic. Then what you do, you think of certain conditions. In caseous, think of tuberculosis or fungal. Coagulative, think of one of the vasculitis. Fibrinoid, vasculitis, autoimmune. Basophilic, vagus. Suppurative, think of fungi always or parasite. Granular eosinophilic, this collagenolitic, then you have got these diseases which called, there are certain group of diseases which occur mainly in the skin, granuloma annular and so on. Neutrophilic, again think of fungi. Then you can do special stains to identify them. Sometimes you'll not. Please note, search for granulomas near the blood vessels. If you are searching for granulomas near blood vessels, look for granulomas elsewhere. With necrosis, you can get this in sarcoidosis. Okay. If there is fibrinoid necrosis in the wall of the vessels, it is likely to be an autoimmune disease. If it is basophilic, think of vagus. Right? If it is necrobatic or collagenolitic granulomas, like I told you, if it is blue in color, then if you do a mucin stain, if it is rich in mucin, then it's a mucinous necrobitic granuloma. Think of granuloma annuli. If it is rich in neutrophils but no mucin, think of vagus or rheumatoid vasculitis. Blue granulomas. That is, they're mainly blue in color. If it is eosinophilic, then it's typical collagenolitic. It could be necrobiotic xanthogranuloma, rheumatoid nodule, Church-Strauss, or necrobiosis lipoica diabeticum. It depends on the location and other things, so we will talk about them later. You also have elastolytic granulomas where the elastic tissue is destroyed, right? You have two types, elastolytic giant cell granuloma and actinolytic elastolytic granuloma. These are the two. Ma'am, can you come over and show the tuberculosis cases?
Yes.
I'll stop sharing the screen.
So I have 3 cases, and thank you so much. I really enjoyed all the different granulomas, and there's so much to granulomas. The first time I realized. So let me show a clinician's perspective. How do we see cases and we refer the patients for a histological diagnosis? Along with that, what other investigation we should send, and how a clinical picture will help you as a pathologist talking or discussing with your clinician colleagues to decide or come to the final diagnosis. So young lady, 28-year-old, she had TB in the past, March 22, was treated at a native place. Again, she had recurrence of symptoms in May 2022, fever, weight loss, and typical symptoms. And so she was treated with AKT again. August 22, she detected to have pleural effusion, and she was started on first-line anti-TB treatment. She also had recurrent abdominal symptoms. Now we investigated her. This is the X-ray chest. You can see here, not much is. Yeah, I want to see the. So the X-ray chest. What you normally see is try to look at presence of any lymph nodes. So here there is no obvious lymph node that you can see. Let me just see the pointer.
You can click on the right side of the mouse. You'll get pointer options. Just click on the right side of the mouse for both fingers on your touchpad. Otherwise, you can use your arrow.
Okay, I'll use the arrow. I'm able to see the arrow. Okay. So this is commonly lymph nodes you see here in this area. It's called paratracheal area, right and the left paratracheal, and the hilar area, the right hilum and the left hilum. And so here the paratracheal and hilar area look normal. We try to look at the costophrenic angle, costophrenic and the cardiophrenic angle for presence of any pleural effusion. We try to look for any lesions in the parenchyma. So we divide into 3 zones. This is upper zone, mid zone, and lower zone. So here you can see more or less the X-ray looks normal except for some possible abnormality in the upper type area. Now we did CT scan for this patient and she had abdominal nodes also. We biopsied that, but the culture was again inconclusive. So we somehow wanted to diagnose it because the third time she's got TB and she was not clinically responding. So we did the PET CT scan and you can see here there is this right upper lobe lesion which is showing a good uptake. Her SUV was pretty high, more than 8. You can see here the hilar lymph node which is having uptake, which was not evident on the chest X-ray. And this is the same lesion in the right upper lobe. So ultimately we decided to biopsy this lesion, do the histopathology and send it for gene expert. So one important thing here is whenever we are suspecting TB clinically and radiologically, it is very important to send the tissue, one in formalin for histopathological evaluation and second sample simultaneously has to be collected in normal saline or sending for gene expert AB smear, AB culture. And if you are suspecting anything else, then bacterial culture or fungal culture. So that is very important because many times we get histopathological confirmation of drug tuberculosis, but that's not enough for us as clinicians. We have to rule out drug resistance. And culture is also important because sometimes non-tuberculous mycobacteria can also get similar kind of granulomatous inflammation. And unless we do the culture, we will not be able to differentiate. So this is very important. So here we did see necrotizing granuloma on pathology, and gene expert unfortunately was inconclusive because it was just trace, and we are waiting for the culture report to come. Now second patient, a 65-year-old male, known case of type 2 diabetes, came with fever, cough and weight loss, and sputum evaluation was done being a diabetic and having cough, fever, weight loss. The commonest diagnosis would be TB, but sputum gene expert was negative. Then here, because he was elderly man and he had got his USG abdomen and CT scan done at his native place, and so there could be a suspicious of lymphoma needs to be ruled out. Now here on the CT scan you can make out that there is this paratracheal lymph node, a big lymph node. Another lymph node you are seeing is this is in subcarinal area, so it's a large lymph node, and along with that you are seeing cavitated lesion in the parenchyma. So with this cavitated lesion, diagnosis of tuberculosis was much more likely. But we did the bronchoscopy, and here with the bronchoscopy we did endobronchial ultrasonography, that is called EBUS, and did the fine needle aspiration biopsy and aspiration both. So actually here in BAL we got gene expert positive and it was RIPA sensitive. And in EBUS we saw non-necrotizing granulomas. So sometimes in tuberculosis also we can get non-necrotizing granulomas. So this patient was a case of drug-sensitive TB. Now it is very important for us clinicians when we are doing a invasive test, it is better to collect sample from multiple areas and send it for multiple tests. So that's important because we cannot repeat the test like bronchoscopy or EBUS repeatedly. So it's better to send the tissue also for culture as well as histopathology and BAL sample for cytology as well as for the microbiological evaluation. And this is the third case, a 30-year-old female. She presented with cervical lymph node. It was biopsy proven TB and drug sensitivity proven on the gene expert earlier. She had a cervical node which we could biopsy. It was very easy to biopsy. But after 3 months of TB treatment also there was no clinical and radiological response. So we repeated a CT scan chest. It showed multiple mediastinal lymph node. And in CT abdomen it showed multiple abdominal lymph nodes and there was obstruction of the common bile duct. And she developed jaundice, so I believe it was 6. So biopsy of the abdominal lymph node was done. So how non-invasively you could do a biopsy, a less invasive procedure. So we did endoscopic ultrasound through the esophagus. We did the biopsy. The histopath showed a necrotizing granuloma, and gene expert again proved that this is a drug-sensitive TB. So these are 3 cases. This is here. You can see the X-ray in this patient. See this paratracheal region. It is showing large paratracheal lymph. So she had paratracheal lymph nodes, both left as well as right. And this is the X-ray which is done after 3 months. And since it is not showing response, we have to do the CT scan and repeat the test. So these are 3 cases of tuberculosis that I had to share.
Thank you, ma'am, for those cases. I think what is most important point that you have said is that when you get the tissue, please send it to for proper investigation in addition to pathology. I think that's a very important lesson that all of us.
If I permitted to say
Yes,
one
Dr.
thing,
Saran, please.
one very important thing Dr. Dalal has said, and that is very important for all the pathologists to do, that the upfront drug sensitivity. Even in the National Tuberculosis Eradication Program, they said it whenever you are testing for anything tissue or anything for tuberculosis, send it for CBNAT or riboflavin and INAT sensitivity. So nowadays, for pathologists to diagnose tuberculosis is not a big deal. We have to give upfront to the clinician and sending the tissue to CBNAT or the gene expert equivalent or any platform to say that before the start of treatment of ATD, clinicians should have a report with them whether it is riboflavin sensitive and INAT sensitive or not. Because that is the crux of the thing for the whole of the tuberculosis treatment, and it is aligned with the National Tuberculosis Eradication Program. So that I wanted to tell you. This is
very important point, sir. And see, generally when a pulmonologist sends to the sample, the pulmonologist is aware. But many times you will get samples, extra pulmonary sample from surgeons, and that's where when they have low pre-myopsy suspicion of TB, they will end up sending the sample just for histopathology, and we've lost the opportunity to test. And this is still happening very commonly. So as a pathologist, when you talk to your surgical colleagues, you have to make them very aware that even if you have low suspicion of tuberculosis, please do send the sample for gene expert and AP culture in the same sitting.
Thank you, ma'am.
And another point which is very important, that all the tuberculosis patients who are on ATD, even then they drug is sensitive to them, many times the cervical lymph node or any other the abdominal lymph node things, the first initial 3 months, 4 months, even the lesion size can increase, despite being the drug sensitivity. And that is another very important point. Because of so much necrosis of the drugs and inhibition of the osmosis, the size of the lymph node tenderness they increase, and clinician many times think that it is not, as in your third case, you have repeatedly done different methodology of aspiration and doing, and then finding again that it is sensitive. So this is the thing which a pathologist should have to keep in mind, that despite the treatment with the standard protocol with adequate compliance, everything, the size of the lymph node can increase in some of the cases. So that's another. Yeah.
So iris is very common, and it's seen more in lymph node TB. It's seen more commonly in CNS TB and pleural TB.
Yeah.
I think now we'll tell Sudhir to take over the other cases. Yes, Sudhir, please share your screen.
Yes,
Ma'am, you can stop sharing the screen. Yeah.
Yes.
Yeah, okay. Sudhir.
I stopped the screen.
Okay, Sudhir, you can.
Yes, sir.
Yeah.
Yes, sir.
Go down to the case 3 onwards.
Yes, 3. Who will be taking the case 3?
Agam.
Yes, sir. So mental age male presented to pulmonary medicine OPD with complaints of shortness of breath and fatigue since 3 months. Recently, he developed blurring of vision and papillary skin lesions on extremities. Biopsy from lung for interpretation.
Agam, I will not go to the next slide. By looking at the history,
Yes, sir.
what do you think?
Sir, it looks like an autoimmune disease, sir, involving multi-system.
Why not
Blurring of-
disseminated lesion? Why thought partly?
Sorry, sir.
Why not a disseminated lesion? Disseminated infectious lesion?
Uh,
Is there any possibility?
sir, fever would.
Fever can occur, yes. Even in autoimmune disease, you will have fever.
Fever, yes,
Even
sir.
in disseminated infectious diseases, you will have fever. So when the patient is having multiple lesions, why the clinician thought that I will take biopsy from the lung?
Why not from the skin, Agam, that's what he's asking.
Yes. Why not from the skin? I agree that here's a blurring of vision. You cannot take biopsy from the heart, from the eye.
So the chances of finding a granuloma might be higher in older lesions, sir.
Because we are talking about granulomatous lesions, I think only about granuloma. That's great, good. So, Agam,
Yes.
I'll just ask you one thing. So, Professor Siddharth Dattagupta sir has beautifully, so you are very lucky to have sir on board and listen to his lecture. So, thing is, whenever you have a granuloma, think that you are a granuloma. How often do you see granuloma in a routine day-to-day life in your laboratory? How often do you see?
Sir, very often.
How often? Maybe 1 to 2 cases per day?
Yes, sir.
Right? All of us. So,
Yes.
thing is, the granulomatous lesions or diseases of any system, it is one of the most common, even in remote medical colleges hospital, where you will see 1 to 2 cases of granuloma, right?
Yes,
How
sir.
often are you satisfied with your diagnosis once you see and report a granuloma? How often you are right? Think that yes, I have seen 2 cases today. All my 2 cases are 100% right, correct diagnosis. I'll give correct diagnosis. How often do you feel like that? You will not follow. So why I am telling you this is, see, identifying granuloma, pathologists should not be only limited to the slides. So it is a bridging field for both clinicians, okay, and the basic pathology. You have to identify the disease. Okay, you have to, instead of clinicians, if they are having 100 differential diagnoses, it's your duty to narrow it to few differential diagnoses, carry out further special stains and necessary other investigation to come down to the diagnosis. If possible, you have to direct the clinicians for proper patient care and management, right? So granuloma, right? See, granuloma, if you think n number of diseases can have granuloma, name any diseases, somewhere or other they might show granulomatous infection, right? So because in this patient, he is a middle-aged male, and just go about, he had a presence of shortness of breath on clinical history, right?
Yes, sir. Sir, the history is probably long, so chances of disseminated infection is less likely.
Fine. So why? Because he is having fatigue, shortness of breath, fatigue since 3 months. It's quite acute or subacute kind of it. Quite with a 3 months duration. If you are suffering, you also feel it's a long duration suffering. That's what the clinician thought he will take biopsy from the lung. So we'll see what biopsy shows.
So there,
Sir.
another point, Agam. See,
Yes, sir.
whenever this, such a thing happens, obviously you would have undergone at least a chest X-ray.
Yes.
Yes, sir.
And there must have been something in the chest X-ray. And of course, other investigation might have prompted for a lung biopsy. Okay, tell.
So one thing you should remember, Agam, so whenever there is a shortness of breath, the pulmonary involvement, one routine X-ray and high-resolution CT of the chest is must, to see the disease distribution and its severity. Okay, that, after that, clinician thought something else, some diseases of the lung, so he took biopsy, and this is the biopsy what we are observing. I want your description.
Yes, sir. Sir, the section examination shows well-formed, discrete, naked granulomas along the left side.
Agam, try to identify the tissue first.
Sir,
Divyanshu, sorry, Divyanshu, there's some sound coming, no? Are you all hearing?
Background.
Background, yeah.
Background sound is coming. Yes.
I think, okay, now it's gone.
yes,
Yes. Devanshu, can you see my arrow?
Yes, sir.
yes, sir.
What is this?
So these are lymphatic channels, sir.
That's what I told you. You have to identify. I already told you that biopsy is taken from the lung. Right? What are these structures?
Alveol.
These are all alveoli. No? These are each one thing. The hexagonal structures are alveoli. They are separated by interalveolar septate. And this part of the lung looks perfectly normal. Perfectly normal. So first thing all of you should remember is try to identify the tissue first from where the biopsy has come. So if it is come from pulmonary, obviously we will know that it is from lung. But most of the time, what ma'am said, it will be from surgery where they will not even write anything on the form. We have to assume everything. Right? So identification. As a resident, you have to identify the parent organ, the tissue first. Fine. This is a lung. You are confirmed that it's a lung.
Yes, sir.
Do you see alveoli anywhere else in any other organ other than lung?
No, sir.
The alveolar structures. Okay. Then what do you see?
Agam,
Pathology.
you should be very careful. Supposing there is blood in those spaces, no?
Yes.
Don't mistake them for cavernous hemangioma. or
Cavernous
something.
hemangioma.
Okay, it looks almost like that. The new residents sometimes mistake. Okay, very
And
good.
one more important
And
thing.
in the edge,
Edge. Yes.
what is that edge?
What is happening here? Can you describe this?
Yes, sir.
The pathology. What are you seeing here?
Sir, we are seeing well-formed, discrete, naked granulomas along the periphery and just beneath the pleura, sir.
Beneath the pleura. And here they are discrete. Very good.
So in the next slide,
No, I'm not going to next slide. Tell him this slide only.
sir, they are naked granulomas, sir, without the lymphocytic collar.
Okay.
And sir, surrounded by fibrosis, sir. Lot of fibrosis.
Yes, there is a lamellated fibrosis. Right? You want
Yes.
to comment anything other than this and just magnification?
Sir, punctate necrosis is also visible in areas of calcification, sir.
Here.
Sir, toward just beneath, yes, sir, beneath the pleura, sir.
Here?
Yes, sir. This
These
one.
are all multinucleated giant cells. These are well-formed epithelial cell granulomas. You said discrete, located in the subpleural region and also somewhere in the alveolar parenchyma. See, lung parenchyma in the alveoli. Each granuloma, you said they have poor lymphocyte cuffing. See, identify each and every component of it, right? And some of the granuloma, so majority of the granuloma, they show some kind of a lamellated fibrosis which is present at the periphery. And do you see necrosis?
Sir,
You cannot make out at this magnification. You want to go to higher magnification.
yes, sir.
Right? Okay, I'll go to the next slide. Yes.
Sir, here the granulomas are trying to police, sir.
Yes.
Sir,
Yes.
I think,
Can you see my arrow?
yes, sir.
Take out this granuloma. I can easily separate this granuloma, and this granuloma.
Yes, sir.
Okay. So do you still call it as a confluent granuloma or discrete granuloma?
Sir, they're trying to police, sir. I would say confront granuloma, sir.
would say granulomas. ठीक है. The confluent. Okay. Next slide. Higher magnification.
Sir, I thought that yes, sir.
Agam, are these granulomas located near blood vessels or bronchi or just lying here there?
Is there any peculiar distribution, or they are just randomly present everywhere?
Sir, along the lymphatic channels and blood vessels, sir.
Where is the lymphatic?
Can you show lymphatics here? Can you see lymphatics on HND in lung? Easily can you make out? What structure is this? Agam? Yes. What Agam? Can you hear me? What structure is this?
No.
There is
So
one yes.
Sir, I'm not sure, sir.
Right, so I'll tell you. You just have to think. It is a round structure, tubular thing.
Yes,
It's
sir.
got a thick wall and few RBCs in the lumen. What structures it could be?
Vessel, sir.
Yes, it is a vessel. So you need to identify, as a resident, you need to identify the day two structures. How to identify? All of you should know the histology much. So it is a vessel. There is a full granuloma here. And what structure is this?
Sir, nerve.
Why do you say it's now? It's the lumen here. There are a few RBCs.
Sir, neurovascular bundle, I would say.
No, why nerve? Is it a nerve bundle or a vessel?
Sir, this is vessel, and just above it there is a nerve, sir.
So this is actually, if you think, the extension of the same vessel. This vessel is continuing here. It is tangentially cut. Can you see the lumen?
Yeah.
Yeah, it's a tangentially cut vessel. And where are these granulomas located?
The perivascular, sir.
What structure is this? Can you see my pointer here? Again, there is.
Sir,
It is also a blood vessel. See the granulomas where they are located?
perivascular, sir.
Perivascular location. So predominantly the granulomas are perivascular vascular location. And what are you seeing in the center of this?
Sir, I thought it to be a calcified or punctured necrosis, sir.
The thing is, in HND, whenever you have a calcific deposition, that will be bluish in color.
Yes, sir.
Either amorphous, nodular, bluish in color. Unless until you see that, don't comment that it is a calcification. Right? Identification of calcification, is it helpful for you to give a definitive diagnosis in this case?
Sorry, sir.
Identification of calcification or observing calcification in these granulomas, will it be of help to give a definitive diagnosis?
Yes, sir.
What if you see calcification, what do you think? If you don't see calcification, what do you think? See, identification, sir has already mentioned this. Schaumann bodies, rasteria bodies, although they are present, Schaumann bodies are lamellated calcification. It will not be of helpful in identifying or giving any definitive diagnosis. They can be seen in n number of cases. So for resident, all of you should remember, whenever there is a degeneration of any etiology, any infectious diseases of chronic long duration infectious diseases, where there is necrosis, collagen degeneration, they are intended to have calcium deposition. Right? So identification of calcification is not helpful to give or come to a definitive conclusion.
Okay.
That's all of you should remember. I'll go to next slide. 1 second. Okay. Describe where these granulomas are located. These are interalveolar septae. Here's septae, one alveolar line here. This is the interstitium, one more alveoli, and again there is one granuloma here. So these granulomas are located in the interstitium, alveolar interstitium. Right? By looking at it, see, there is one more granuloma here, and there is no necrosis. So whenever you see granuloma, one thing all of you should remember, and you have to include in your report, is whether there is in developing countries like India, granuloma, if you're describing, mention whether the necrosis is there or not. It is an important negative finding. You have to include this in your report. Right? So what do you think? By looking at all the observation on this, what you want to do next? Yes, we found granuloma. There are multiple granulomas. Something are discrete. Some of them are, you said, becoming like confluent. No necrosis. What do you think, and how will you go about in this kind of cases?
Sir, I think it's a case of sarcoidosis, sir.
You will give a definitive diagnosis of sarcoidosis.
Sir, multi-system involvement, and sir.
So what you will do next in this case?
Sir, if we can do a, sir, there are various, sir, CD4 to CD8 counts, the ratio of help in diagnosing sarcoidosis, sir.
In ball fluid.
In ball fluid, sir, yes, sir.
Okay. In this case, what you will do? You have a biopsy slide with you.
Sir, we can stain it with serum amyloid A, sir.
Why?
So it is used in diagnosing sarcoidosis, sir, specifically. And we can.
See, whenever you have a granuloma, first thing you have to do is to exclude all the possibility of infectious diseases.
Sir, Zidane staining, sir.
Do Zidane staining.
And sir, pass.
You will do fungal exclusion.
Sir, GMS and pass, sir.
You will do. Then anything else to confirm that these granulomas are of sarcoidal origin? Diagnostic of health. Yes, Gokul.
Reticulin stain, reticulin
Yes, important one thing is reticulin. What do you expect in this patient?
reticulin rich granulomas are phleotomatic sarcoidosis and reticulin deficient granulomas, lead necrotizing granulomas in TBs.
Do you see reticulin rich granulomas in tuberculosis?
We can see.
You can see.
Yeah,
Initial stage of granuloma, there is no necrosis. Okay. So these are just an additional features. And so why I'm highlighting this is in this granulomas disease, especially lung, is one. Although you see granuloma every day, the classical cases what we describe or what you study in the book is just a tip of an iceberg. Okay, most of the things you will not see the classical cases of tuberculosis, a classical case of sarcoidosis. So you have to have a multidisciplinary approach. Call the resident. You will learn yourself. Get the history. Talk to him about the clinical findings. Talk to him about what all diagnosis they have done, what all investigations they have done. So you can give a good diagnosis. So this has to develop each and every resident at your institute. Resident discussion should develop. Right? So one thing. And identifying granuloma is not only thing, the distribution of granuloma, where they are located. This is very important for you to give a typical clues along with the history. So history I mentioned, this patient had a skin lesion.
and this patient had blurring of the vision, and a lung biopsy, you have a discrete, multiple, non-necrotizing lymphocyte core granulomas with peripheral lamellated type of fibrosis. Okay, so this, after discussion with the clinician, ophthalmologist here, and the dermatologist with the pulmonologist, you can come to a conclusion that it is a case of sarcoidosis. So why I'm telling you, highlighting here is multidisciplinary approach. All of you should, although you think that the case is very simple, but the diagnosis can change if you have a proper multidisciplinary approach. Right?
Yeah.
You have to develop. Yes, sir.
No,
Can I add
I
something?
just wanted to tell, you see, the first two cases we discussed was just a general thing, Now it is organ specific, most of them. So you have to identify the organ, the stepwise method, identify the organ, identify the location of granuloma and how it is going about. And what he said was, invariably you have to do a clinico-pathological correlation. They may do a serum ACE level, the HRCT findings would have been specific, and so on and so forth. There are several things. Ma'am will, I'm sure, add to all the clinical things.
Yeah.
So that is how we achieved it. Yes, ma'am.
Okay. Yes. Yeah, I have a case of sarcoidosis and CT scan. You want me to show now?
Yes, you can show it. I'll just stop.
And then you'll talk about some of the other differentials.
Yes.
Yeah. So yes, this is a very important point I want to think about. First, let me show the case and then I will tell. So 35-year-old male, history of malaise, occasional fever, dry cough, and dyspnea on exertion, which was progressing. So he has skin lesion, which was suggestive of erythema nodosa. So we did his CT scan, and you can see here in the CT scan, you are seeing multiple random nodules and the distribution, some of the peripheral nodules, which is quite classical of sarcoidosis. And you are seeing multiple reticular opacities here, the septal thickening you are seeing, and randomly distributed nodules. You can see here. And also here the hilar lymph nodes, you can see these are the hilar nodes. And yeah, this is the mediastinal window. You can see here this is a big subcarinal node. This is a hilar node. So classically, compared to tuberculosis and sarcoidosis, you will have nodes which are more extensive involvement, along with these kind of parenchymal nodules and absence of necrosis. But again, this is not always there. Sometimes growing nodes can show area which is on CT scan appears like a necrosis. Histopathologically, you may be able to differentiate, but radiologically, that necrosis may not be. You may not be able to differentiate. And we did the bronchoscopy in this patient. And here we combined bronchoscopy with EBUS, which is endobronchial ultrasound. And even the endobronchial mucosa had typical appearance of sarcoid, sarcoid involvement. So we did biopsy from the endobronchial tissue. We did biopsy from the transbronchial tissue, transbronchial lung biopsy, and we did EBUS lymph node sampling also. And all three things did show us non-necrotizing granuloma. But here I would like to say that even for a pathologist to confidently say that this tuberculosis can be ruled out, it's very difficult. Sometimes in early stages of TB, we may get nodules, we get granuloma, which may not be necrotizing. So we always have to wait for the culture report to come. So I had a case which was sent to me by a cardiologist. She had cardiomyopathy, which was quite suggestive of sarcoid cardiomyopathy. She was a diabetic, uncontrolled diabetes. She had a cervical node, and the biopsy was done. This biopsy was very confidently reported by the pathologist as a non-necrotizing granuloma suggestive of sarcoid. But I was not very comfortable because there was some history of weight loss, and in diabetic, sometimes we may not get classical fever. Mantoux was done when Mantoux was positive. So I was not very confident of starting this patient on steroid. So I started steroid along with antituberculous treatment, awaiting the culture report. And after 6 weeks, the culture came positive, and on that culture, we showed that this was a drug-resistant TB. So had I been, had the clinician or pathologist been very confident of sarcoidosis as a diagnosis and put this patient just on steroid without anti-TB treatment, it would have been disaster. So this is very important and also very common. I mean, not very uncommonly we see tuberculosis and sarcoid existing together. So one of the theories, sarcoid being upset where antigen could be tuberculous antigen. So we see coexistence of tuberculosis and sarcoidosis also. So this has to be when you are reporting a patient of sarcoid-looking granuloma. So interacting with your clinicians is very, very important in this situation.
This is okay.
An important point I can understand.
Yeah, and here again, we additional information that we got on transfrontal biopsy that there was evidence of fibrosis and architectural distortion also. So this gives me additional that sarcoid is progressive and is already gone into a fibrotic state.
One important question can I ask and have an opinion?
Yeah.
How many times in sarcoid, the peripheral pleural space, they have a reticular shadows, and then the biopsy from the open biopsy is done, as Dr. Sudhir was showing the sarcoid. Because sarcoid, what we have read it is conventionally paratracheal, para-aortic, large, big nodes, and then have some very major bronchus, some reticular shadows dot. So can you highlight the importance of classical presentation of the sarcoid from the chest X-ray CT point, and then the multiple shadows to this, where the subpleural biopsies are going to yield? Because main site of biopsies are the EBUS or maybe the FNA or whatever from that. That's what I remember. So please just clarify those points. That are the very important point for the pathologist to all the time think about. Yes, Dr. Rao. Oh, you're muted, I think.
Yeah. So you were saying pleural biopsy?
Yeah.
So how often do we take pleural biopsy in sarcoidosis?
Yes.
Yes. So actually, pleural effusion and pleural involvement is not so common in sarcoidosis. You see, few cases we have seen which patient with diagnosed sarcoidosis or patient presenting with pleural effusion, recurrent pleural effusion, and all our tests for gene for AV culture all come negative. And then we do pleural thoracoscopic pleural biopsy. We find granulomas. But I mean, sarcoidosis presenting with pleural effusion in our practice is much less common. Much less common.
When you come across with a classical case of pulmonary sarcoidosis, with serum ACE levels elevated, calcium level elevated, ADA is, in case if the ADA is less, and Mantoux is negative, do you still go for biopsy?
Yes, see, in case of sarcoid, we would always like to confirm a diagnosis and send the tissue for cultures because because there are such close mimics. Both the thing. I remember one of our teachers many years back used to tell us that sarcoid and tuberculosis is like that old movie Sita and Gita. They look so alike, including the system that they affect, that we would not like to treat these patients without confirming a diagnosis. And all the tests, the diagnostic yield of sarcoidosis is pretty high, even in a bronchoscopy, transfrontal biopsy, or even lymph node biopsy. So we would like to usually go for the tissue confirmation, and because ACE level again can be non-specific, we see ACE level being high in tuberculosis cases. Sometimes ADL levels coming low in pleural effusion. So all these are not very specific findings, and we would like to always confirm with the biohistopathology and culture.
This is just a message for the residents. So whenever the clinician thinks that it is a case of pulmonary tuberculosis, pulmonary sarcoidosis, the what biopsies you will receive here is bronchial biopsy. You have to see the submucosal location of these non-caseating granulomas. One thing. In addition, you will have transbronchial lung biopsy where you will see tiny granulomas, as I said, arranged along the lymphovascular location. Okay, so these are the two biopsies. And in addition, if the patient is having a mediastinal lymphadenopathy, you do get EBUS FNAC specimen also just to get the non-necrotizing granulomas. So these are the three important specimens we do get in sarcoidosis. In case cytology, we may get a ball fluid analysis also. So that is for the residents.
The residents must understand that the treatment is too different
Yes.
between tuberculosis and sarcoidosis, and a lot of things are at stake. So therefore, you have to try to, as Sudhi said initially, narrow down and come to as close a diagnosis as possible and help the clinician.
Absolutely.
With this, can you see my slides?
Yes.
Yes. Okay. So as
Before we go to, there is some request to
Yes, sir.
Dr. Gupta, where the 6 more cases are there, we have to be a bit fast.
okay, we'll go faster.
Please,
So these are the classic. Fine. So these are the.
So there's one thing. Two people have said, why not it is Wegener's? You know, it's you can tell them. Actually, Wegener's, no, there'll be a lot more neutrophils. The necrosis is a little more bluish. You will not get like this very commonly, like in sarcoid. Very rarely it looks like this. So,
And these are located at the periphery of the vessel, not destroying the vessels. That is to say, it is vasculitis. The inflammation should destroy the vessel wall.
and plus, you will get fibrinoid necrosis,
Fibrinoid necrosis.
neutrophils, and other things. Which
Yes. Even in sarcoidosis, you may see lymphocytic vasculitis also occasionally, but the necrosis of the vessel wall you will not see. So these are the reticulin-rich granulomas. Around the side, we'll go ahead. On contrary, if you have tuberculosis, they are reticulin-poor granulomas, right? So if you see, there are few cases. See, this patient, middle-aged male, presented with this tiny papules, just behind the ear, even on the forehead. The biopsy has been taken from these, and it shows this multiple, discrete, well-formed, non-necrotizing epithelial cell granulomas. All of them are reticulin-rich. Okay, so when you see this kind of granuloma with the fibrosis at the periphery, naked granuloma, so it is a case of cutaneous sarcoidosis. Even 1/3 to 1/4 of pulmonary sarcoid patient, they may have cutaneous lesions. So this is asteroid bodies, Schaumann bodies. This is not specific. If you identify, it's well and good. Okay, sir, can we go because we have to finish? Shall we? You are mute, sir.
quickly show this. Just
Okay. So why I'm highlighting here is the approach to this granuloma should be very diligent. It's not like as we think. The distribution and excluding all the possible causes, etiology of the granuloma is important. See, this patient, he presented with recurrent onsets of mucosal edema from past 1 year. It's on and off. Biopsy has been taken in this from the lip. If you see that there are multiple granulomas, one granuloma here, tiny granuloma here, a lot of chronic inflammation, and even the inflammation is going deep and this is the perioral musculature, skeletal muscles, and there is a non-necrotizing granuloma. So in this, when you have a clinical picture along with the other supporting investigations, this will fall into orofacial granulomatosis. It is not tuberculosis or it is not sarcoidosis. So that's why the importance of multidisciplinary approach in these granulomas are very, very important. Okay. Again, I will not show this. I'll show this. Can anyone describe fast? What are you seeing in this? See, again, there are, I'll just inform you. There are tiny cells, ill-formed granuloma, they are there. It is a granulomatous inflammation, and there is dense lymphocyte covering around the granulomas. No necrosis. Now, see what granulomas, where they are located, what they are causing in the skin. They are destroying the rectal pili muscles. They are present in the very adnexal locations. Okay, so when you have this kind of appearance, you are always think, without any doubt, you should think of that it is we are dealing with leprosy. Okay, so when you see this patient, this is the patient who presented with the annular rash with hypopigmented area, and the clinical diagnosis was BT Hansen's. Again, it is a granuloma, non-necrotizing granuloma, but see what is causing this location, perivascular location, neurovascular bundle location, destruction of the rectal pili muscle. That will be of help for us to diagnose it as leprosy. Always you will do modified AFP in these things. You see this deep granulomas, they are causing destruction of the rectal pili muscle. See this granuloma causing damage to the rectal pili muscles. Whenever you see like this, you think that I'm dealing with leprosy. Again, there is one more case. Here it is a nerve fragment. Whole nerve, there is dense inflammation. Again, you are seeing granuloma in the nerve. This patient came with pure neuritic Hansen's. Nerve biopsy was done. Neural inflammation with the granuloma. Again, it is the feature of leprosy. So they should know the location of these granulomas. It is important. This I'll skip. This is a single tiny subcutaneous nodule. It's excised, and the sets like spindle cell granuloma-like lesions. Whenever you have this with interspersed foamy histiocyte, just boost AFP stains, and you'll see this glow by of acid fast bacilli with high bacillary index. So it is a histioid leprosy. Importance of these are infectious granulomas. And see this patient had a big plaque on his forearm, and there is necroptosis in the center. Biopsy it has taken. See this again, it's a granuloma. Can anyone describe this fast? Any resident? What is happening? Where it is located? Which structure is this? Agar?
Gokul.
The granulomas are located in the subcutaneous region.
Yes.
And there is clear.
See, there is a very big granuloma, right? Very big granuloma. What is there in the center? There is wavy structures in the center. There is no caseous necrosis. There is some gap here and lymphocytic infiltration this here. By looking at this, what do you think? There is no necrosis. All histiocytes, there are giant cells, and I'll see. Let me go to the next slide. If you see that these giant cells, they're causing collagen fragmentation. Even if you see it, if you do empty scan, some of the giant cells they show collagen fragments in their cytoplasm. So what does that indicate? The thing is, if you call this as tuberculosis or if you call this as leprosy, just by looking at a granuloma, I know only few granuloma, you can think about the treatment. 6 months to 1 year treatment, the patient will be receiving. All those are toxic drugs, hepatotoxic drugs. No? So diagnosis is very, very important. So sir mentioned that two things. One is infectious granulomas and non-infectious granulomas. Do you call it as infectious granulomas?
This is non-infectious granuloma.
Why do you think so?
There is no lymphocytic reaction.
It is there here. So whenever you see, sir also mentioned about two granulomas, blue granulomas and red granulomas. Red granulomas usually seen in necrotic infectious granulomas where you have caseous necrosis in the center. along with a few cases of red granulomas, non-infectious, they show collagen degeneration. Here there is a collagen degeneration. Whenever you see this kind of picture, always try to carry out the Alcian blue prostate. You have to demonstrate the presence of mucin. That's why they're called as blue granuloma. Even in HND, the mucin, you can see that there is a bluish hue in the center of these granulomas. That can be demonstrated very well by doing special stains, AB pass. So hence, are you agree that it is a blue granuloma? Right. So if you know the clinical history of this patient, if you know the clinical appearance of the lesion, the diagnosis is very simple without any doubt. It is a case of granuloma annulare. Right. So that's why the multidisciplinary approach and is very important. This is again one more case. Can you see, Gokul? Same thing. There is a lot of collagen. These are all wavy collagen bundles which are fragmented. There is bluish material expressed is here. This whole area is totally necrotic and collagen degeneration, and there is palissaded histiocytic arrangement surrounding this collagen degeneration. What do you think?
Rheumatoid palisade,
Rheumatoid nodule. So this is how you should approach it. Even in the center, this collagen degeneration, necrobiotic degeneration, collagen degeneration, and here you have palissaded epithelial histiocytes, histiocytes. Even you see multinucleated giant cells. If the patient is having a joint pain with increased RA factor, no need to think of anything. That's what it makes the treatment and diagnosis very simple. If you just call up your resident and ask about the clinical history of the patient. All of you, I request all of you, resident from the first year, make a habit of calling. That's what we learned from Dr. Siddhartha Gupta sir. Call up the clinicians. Resident clinician will develop the bond. Will learn many clinical scenario of the disease. So please develop this habit in all. Again, if you see this, the clinical presentation is a small, tiny capules on the skin. Biopsy has been taken, and it shows granuloma located in the papillary duct. Have any? If you say this as tuberculosis or leprosy, clinicians will not send any sample to you from next month. The clinician dermatologist, the classical presentation is like an ichthys. Like an ichthys. This is non-infectious granulomas. They know it is like an ichthys. And the pathology, if you know the clinical picture, presence of granuloma, whether well-formed or ill-formed, or tiny histiocytic collections in the tip of the dermal papillae without giant cells, you can call it as like an ichthys, and your diagnosis will be final. So you know the importance of clinico-pathological correlation, right? And can you see what is this? Agam, explain.
Sir, so there is a lot of foamy histiocytes are present in the subepidermal and in the papillary dermis, sir.
Yes, this is the papillary dermis, and this we call it as reticular dermis. Can you see globules, diffuse pandermal infiltration of foamy histiocytes? Can you see central located nucleus and their foamy histiocyte? And if you search for it, you will find these kind of cells. What are these cells? Search nucleus in the center, and there is vacillation at the periphery.
Proton.
Yes.
Proton
Proton
giant
cells.
Your diagnosis will be
Xanthogranuloma.
yes. Now you know the importance of accompanying cells, the location of the granuloma, and their clinical appearance. Clinical features are very much important in each and every case. Although you think that it is simple, but when you have a clinical picture, your diagnosis can change. Right. Next, we'll go to case number 4. Read. I think sir will take this. Sir.
Okay.
Read. Can you quiz?
Just
39-year-old male presented with complaints of chronic diarrhea.
So I'll stop sharing, sir.
okay. Stop.
Okay, I'll stop sharing.
You stop.
Yes.
See,
Yes,
Huh?
yes, please. Yes.
it's there now.
Okay, understood.
Okay. Yeah. Who's taking the case? Hello. Gopal. It's,
A 39-year-old male
yeah.
presented with complaints of chronic diarrhea, fatigue, abdominal pain, and blood in stools. Recently developed mouth ulcers following biopsy for interpretation.
Yeah. Anything you feel clinically?
So clinically, it is looking like inflammatory bowel disease
Okay.
or non-specific colitis,
Okay.
and also recently developed mouth ulcers, and also that it's pointing towards
Okay.
deficiency of vitamin deficiency.
Right. We'll go to the next case. Yeah. What are you finding?
So section shows following biopsy dates. Here the clips are more or less preserved. The architecture is preserved in the initial sections, and in that section we can see there is towards deeper tissue there is some necrosis kind of changes are happening.
Okay. And in this tissue, if you see one thing, here there's necrosis. Here there's hardly any inflammation. No.
Oh yeah.
Okay. There might be other ones. Here there's inflammation more. Here it is less. Okay. Now we'll go to the next one. Yeah.
In this section also, crypt architecture is preserved, but in between the crypts we can see some eosinophilic infiltrates.
Yes.
And infiltrates also. And in the third section we can see discrete endocrine granulomas with Langenstein types of giant cells, epithelioid cells.
Okay. And these areas? This one? This is necrotic, and it might be from an ulcerated area. No? This might be from an ulcerated area. And here, of course, is the higher power of what you had described, the granulomas and other things. Okay. Yeah, these you see, there's very small granulomas, isn't it?
Yes, sir.
This is the better one, which is the larger one.
That's the granuloma.
Yes. Okay. So, what is your diagnosis? Any differential?
Diagnosis, I would like to say call it as a granulomatous colitis. And my main differential is Crohn's disease and abdominal tuberculosis. Tuberculosis. And I would like to do AFP screen in that section to demonstrate acid plus bacilli.
Okay. You know, I say one of the most important things, Gokul, is that for all of you, you know, when you do biopsy, histological evaluation for IBD, so what is the most important thing is, first of all, you must tell your clinician to send in different containers biopsies from different regions. No, rectal biopsy, then sigmoid colon, descending colon, transverse colon, ascending colon, and cecum, and they may do the. You have to examine each of these regions separately because histologically and endoscopically they may be different. If the inflammation, if all the biopsies from the rectum onwards going proximally are showing inflammation, it's likely to be ulcerative colitis. If it is patchy, it is likely to be Crohn's or tuberculosis. Okay, so this is very important, and in our country you have to exclude that. So that is one thing you have to ask. I want to see biopsies from other areas, or these are the only ones. Okay, so and of course for Crohn's, everybody agrees if you see a granuloma, you are more likely to be right. But the problem is, just like in sarcoidosis for pulmonologists in our country, for gastroenterologists, the problem is differential diagnosis of tuberculosis. Both of them look almost alike. So that is one very important thing. Please remember, if you have tangentially cut strips, they may look like a small granuloma. But you see, but you'll find the nuclei are similar to these nuclei, right? And if you do a mucin stain, you'll find mucin. So you must be very careful. This is not a granuloma. Then granulomas associated, if the crypt is destroyed, you see, there'll be mucin excavation and all that. So there might be a granulomatous inflammation. That is not counted as a Crohn's granuloma. The other thing is, if the granulomas are large and confluent, see, this is a confluent granuloma. So then it is more likely to be tuberculosis. If there is necrosis, more likely to be tuberculosis. If the lymph nodes are involved, more likely to be tuberculosis. This is a large small submucosal granuloma. This you can get also in Crohn's disease. See, small ones trying to become confluent. Okay, these are small granulomas. So what is a small granuloma? A small granuloma is a granuloma less than 2 crypts in width. For example, if a granuloma is smaller than these two combined, if it is so small, then it's a small granuloma or a microgranuloma. If it is larger than this, it's a big granuloma. Bigger granulomas
TB.
are more likely in TB. Smaller granulomas more likely in Crohn's. People have counted the number of epithelioid cells. They say if it is more than 25 epithelioid cells or more than 200 micron, then it is a large granuloma. Okay, so microgranulomas are more common. So typically they're a little loose, not as tight as sarcoid, non-necrotizing, non-confluent. Okay, so more number of sections you take, more likely to find granuloma. Okay, this has been studied. More biopsies, more sections, you're likely to find. Others you'll call it ulcerative colitis or some other thing. If the inflammation is discontinuous, see 2 different fragments, no inflammation, more likely to be Crohn's. So when you use the term focal increase in inflammation, it means normal background cellularity with little increase in these inflammatory cells. Patchy means increased background cellularity with focal small areas of increase in inflammatory cells. So this is focal inflammation, typical of Crohn's. See, background cellularity is normal with increase. This you get in Crohn's. This is patchy inflammation. You can get in a lot of conditions. Full background cellularity increase with this. Okay, more than 2 lymphoid follicles if you are finding per millimeter of biopsy, it is abnormal. Submucosal inflammation more likely to be Crohn's or TB than ulcerative colitis. So what is an aphthous ulcer? Anyone? Quick.
Malakoff.
It is an aphthous ulcer. Okay. See, the word aphthous means set on fire or to inflame. And Hippocrates described it mainly for mouth ulcers. Okay. In colon, for Crohn's disease and all, aphthous ulcer is ulceration over a lymphoid follicle. That is what is an aphthous ulcer. Then you get cryptitis, crypt abscess, and so on. At least 2 features: small granulomas, discontinuous architectural abnormalities, and discontinuous inflammation, and focal cryptitis. If you get any 2, more likely to be Crohn's. Inflammation near ileocecal region, more likely to be TB. Inflammation away from ileocecal region, more likely to be Crohn's. AFB is absent. TB, unfortunately, you can get AFB positive in only 5% of cases. But large granulomas, more likely to be TB. So this is a study, and all of them are similar wherever we have studied it. So caseation necrosis, more sensitive for TB. Confluent granulomas, more sensitive for TB. Ulcers lined by epithelial cells, more sensitive for TB. Okay, then I can do AFB and other things. The AFB positivity in TB varies from 2% to 30%. Culture positivity is more; it can be as high as 50%. Then of course you can do the PCR and other things. So you have to compare the endoscopic histological features. If both are typical, then you can treat as Crohn's or TB. One is typical, one is suggestive, then clinician takes a call. But if the changes are not typical, then a follow-up is done. Case 5. Yes.
Can I say something, sir?
Yes,
Okay,
yes,
sir.
please.
One important point is when the patient of an ulcerative colitis is on treatment and he is responding to a very good extent, then the inflammation, everything is down and he is recovering with the near maintenance of architectural pattern. And along that, there is a crypt granuloma. I think you just differentiate from the Crohn's. So how you will approach that one is totally
Yeah.
very good.
You see, if it is a known case of ulcerative colitis, then of course you have to take the other features into account. But for the first time if it comes, then it becomes difficult. Then you have to see whether the inflammation is continuous, starting from the rectum, or it is patchy and so on and so forth. Then only. But mistakes have been done. One has been treated for the other, and later on only, when the disease progresses, the clinician and the pathologist will sit together and find out the disease.
Thank you, sir. Because crypt-associated granomas are many times are in ulcerative colitis, and that is the biggest
Yes, yes.
problem of that. Yes, very nice, sir.
Okay, so there,
Yes, sir. Next, who is going to take case number
I
5?
think the lady is there now. Pratyush.
Sir,
Yes.
21-year-old male with sudden history of death. The sections from the lung were taken for interpretation.
So there,
Sir.
have you shared your screen?
Yes, I shared my screen, sir. Can you see, sir?
Okay, okay.
Yes, sir. Visible.
Yeah, visible.
Yes. The young male.
21-year-old male with sudden death history. The sections were taken from the lung for interpretation.
Why this 21-year-old healthy male will have sudden death? Can you explain what will be the reason? So if you think
One
that
of the
the
reasons.
reason, yes, anything, either cardiovascular sudden death is most common. Cardiovascular. Okay. Let's see. We have taken multiple sections from all the organs. This organ showed classical histopathological features that made us to think and take further history. Right? Observe which organ is this?
So this is a section of lung.
Why do you say it is lung? Fast.
So we can see the alveoli here and the bronchial epithelium.
Yes. So this is very classical. Alveoli, and there is a bronchus here, bronchus bronchiole, and bronchial associated blood vessels. Fine. Next, your observation.
So I can see 2 granulomas here, the second section.
Okay. 1 and 2. Where are they located?
So they're located between the alveoli.
You mean to say somewhere in the alveolar interstitium?
Yeah, interstitium. Sir.
Can you make out necrosis or not at this magnification?
Right, sir?
Are you able to identify necrosis or not?
No, sir.
We'll go to next slide.
Yes, so there, you know, many people have asked, how do you differentiate interstitial granulomas from intraalveolar ones?
Intraalveolar. So, interstitial granulomas means the granulomas present in the alveolar interstitium. So, see this is the interalveolar septum, right? All of you can see there is one alveolar here, one alveolar here. If you find granuloma here, okay, this is called interstitial granuloma, interalveolar granuloma. Intraalveolar granuloma means you see granuloma within the alveolar lumen. Understand? So, just like a hot tub lung disease, all those things you see intraalveolar granuloma. And interstitial granuloma within the alveolar interstitium is placed most commonly because it is the space where you have lymphovascular structures. Sarcoidosis will be the main differentials. Understood? Okay. Yes. I'll go to next slide. Identify. And let's see your observation. So why I'm highlighting is granuloma component, structure, and their location is very important. Right. Again, there are seeing yes.
Sir, I can see granuloma.
Correct. Here one
sir.
granuloma.
Yes, sir.
Okay. There are again granuloma. What structure is this in the fourth picture?
So there is a columnar epithelium. So this is the bronchus.
Yes. And where the granulomas are located? On either side of the bronchus. It is
Yes,
causing compression on the bronchus.
Yes.
Okay.
Yes.
Okay. So there are there any peripheral demarcation in these granulomas?
Yes, sir. There is fibrosis. Fibroblaster there.
Let's see. Let's go to other sections. Okay. Can you still make out where exactly the granulomas are located?
Yes, sir.
Yes. Where? See the third picture. What are these structures?
Are these any secretions?
Some kind of a foreign material.
Foreign material. Yes.
Foreign material that is eliciting granulomatous inflammation.
Yes.
Up to any doubt till now? Where this granuloma located? Third one, and even if you see the fourth granuloma. What structure is this?
Fourth one, please see carefully.
Yeah, see carefully. I'll just highlight the structure. I'll just place. Can you see my arrow? See this? What structure is this? Which has got smooth muscle in the wall. Again, there is.
So this.
Yes. What is this?
Someone said that the slides are not moving.
One second. Slides are not moving.
Not moving. Yes.
No,
No. Can you see these four pictures?
Four pictures are there.
Yes, sir. Yes, sir. So this is the arrow. So let's see. What structure is this? Which has got smooth muscle in the wall and contains the RBCs in the lumen.
This is a vessel.
Blood vessels. These majority of these granulomas they are present within the blood vessel lumen, causing luminal occlusion. Agree?
Yes, sir.
So what can you think? In 21-year-old male presented with multiple granulomas presented within the vessels, some of them are in the interstitial location. They have a foreign material, some structures that is eliciting granulomatous inflammation.
Can it be pulmonary embolism?
Pulmonary edema. Let's see. Again, there are many vessels that I am highlighting here. Can you see? If still you can make out some part of the vessel wall and adjacent lung parenchyma showing what? What is this eosinophilic structure accumulated in the alveolar lumen? Yes, pulmonary edema. Pulmonary hemorrhage, pulmonary edema, associated pulmonary hemorrhage and edema. Right? Yes. And even if you see at high power, there are some polarizable crystalline like that. What is this? Why they are located within the yes. So
Very good.
This very good. Excellent. Good notes. Gokul, excellent. So whenever you observe these kind of granulomas predominantly leading into vascular emboli, giant cell reaction, vague granulomatous inflammation associated with pulmonary edema. So in this patient, I'll tell you each and every slide and almost 95% of the blood vessels were occluded by this granulomatous reaction. When we asked the history, he was a heavy drug abuser and recently he mixed many drugs, many powdered drugs, and some of them are oil-based, some of them are water dissolvable. He mixed in water, he injected in the vein. So this is all because of this IV drug abuser. You should always think the history will solve your problem.
Sometimes, no, the IV drug abusers, talc is very common. Talc,
Yes.
if they mix with this one, there is a bluish material sometimes you get. There are some of the other excipients which are, put solvents which are added with the drugs. There are some polyvinyl chlorides and other things which are there. Sometimes you get that. But this picture is almost typical. You'll invariably polarize and you'll find sometimes.
Yes, sir. See this? All the blood vessels are flooded with this foreign body granulomatous reaction. Either in differential diagnosis. If you don't ask history, you have many differential diagnoses. If the history is straight, he is a heavy intravenous drug abuser. Is there any differential diagnosis in this case?
Nothing.
No. As Sir said, polarizable material, if you can do polarized microscopy, you can try to identify the polarizable material. So he was extensive pulmonary vascular emboli with foreign body granulomatous inflammation with associated pulmonary edema and even pulmonary hemorrhage. Okay. Case number 6.
Sir, so this cannot be possible with only one bout of.
No, he was heavy, long-term addicted intravenous abuser. Not one bout. Yes. So even for giant cells of one body to generate granuloma, you need to have at least 1 to 2 months to develop granuloma giant cell reaction. So it was a chronic case. Next, we'll take case number 6 first. Those who have not taken, you can just
Everybody's taken one, no? Everybody's taken one, each one.
Yes.
each one. Case number 6 was allotted to whom?
Nobody's been allotted. Everybody's in. Sudhir, I think you can describe one by one because time.
Time is as well. See. Okay. Case number 6. Middle-aged male presented with a history of gradual onset of shortness of breath, tiredness, and weight loss in 2 years. Symptoms gets progressively worse over time. On examination, prominent clubbing of the fingers were observed, and lung sections for interpretation. The clinical history suggests that there is predominantly lung involvement. Hence, lung biopsy they have taken.
Acha, all of you have taken at least one case, no?
Yes, sir.
Yes, sir.
Okay. If you are interested, you are most welcome.
Yes. If anyone wants to describe the findings, that's more than sufficient. Anyone volunteer to describe the findings?
Sir, it looks like sir.
Yes. Very good. Yes. Because there is bronchus here, associated vessels here, and the normal lung parenchyma which we saw in previous cases. Can you make out the alveoli? Yes, that means alveoli, there is this severe destruction of the lung parenchyma. The alveoli, the normal alveolar structures are already distorted, and somewhere you see some emphysematous changes, a lot of fibrosis and distortion of the normal alveolar structures. Right? Agree with me? Why there is destruction? The cause of destruction is a lot of fibrosis. There is fibrosis, there is patchy chronic inflammation. Somewhere it is located in the peribronchial location. These are all pigment, anthracotic pigment deposition. And see this, there is a distance between this alveoli and this alveoli, they are increased. Interstitial fibrosis. So whenever you have a prominent interstitial fibrosis, it hampers the oxygen saturation. The patient will present with hypoxemia, easy tiredness, low blood oxygen level. So on the contrary, they will also have increased blood carbon dioxide levels. Okay, so that's why these patients will develop easy fatiguability and shortness of breath, tachypnea episodes. Let's go to higher coma. The same thing, even if you see the blood vessels are also thickened. So whenever you see thickened blood vessels, it is again an indirect indicator that the inflammation or inflammatory disease, what is that, is chronic disease. It causes the thickening of the blood vessels. It can be observed in pulmonary hypertension. Okay, and there is one bronchi here, one bronchi here. So you will not expect so many bronchioles which are lying adjacent to each other in the lung. If you see the histology, right?
So, sir, why can't be this be lematosis in a chronic disease like this?
Yes, yeah, very good observation. See this is actually, if you observe, some part is lined by the alveoli, but other part they are lined by respiratory epithelium. So these are the normal alveoli in which the wall is replaced by a respiratory epithelium. This we call as lematosis that we see in
Usual interstitial pneumonia.
that is one example. Any chronic
Idiopathic pulmonary
any chronic lung diseases, you may have this kind of information. These are also called as bronchiolization of the alveoli.
bronchial metaplasia.
Whenever you have a bronchiolization, again it interferes with oxygen saturation. That all of you should remember. Whenever the epithelium is single layer, it helps in oxygen saturation, oxygen diffusion. When the alveoli is thickened, instead of flattened, it will become columnar. Along with interstitial fibrosis, both together will hamper the oxygen saturation. Right? Any doubts till now?
No.
Yes. Okay. See this again, as you rightly said, there is lambertosis, there is interstitial inflammation, and there is thickened blood vessels. Peribronchial chronic inflammation. Peribronchial chronic inflammation is again important finding for the diagnosis, and the presence of a lot of fibrosis and alveolar destruction that indicates that it's a chronic lung disease. So here till now there is a chronic lung disease with peribronchial inflammation. There are the two observations they have done, and even if you see there is mucus plug formation also, that is impairing the mucus clearance. Again complication. Thick walled blood vessels. Again, can you see this? There is bronchial. This is the bronchi where there is proliferation of myofibroblastia that I'll show you in next slide. Chronic lung disease, fibrosing, peribronchial inflammation, alveolar destructions, mucus plug accumulation within the alveoli. So whenever you have a mucus plug stagnation in the pulmonary parenchyma, these are the rich source of a secondary bacterial infection. These patients will come for recurrent pulmonary infections, recurrent pneumonia, right? Observation. And the important thing is we are finding some kind of this granulomas either within the alveoli. Some of them are present in the interstitium. Okay, and this is the alveoli showing the prominent plump alveolar lining epithelium. It is nothing but hyperplasia of type 2
pneumocystis.
So whenever you see hyperplasia of type 2 pneumocyte, that indicates that there is an alveolar injury and it is undergoing for reparative process. Right? And if you see granulomas, they have cholesterol cleft in the granuloma. Can you make out the diagnosis at this magnification with these findings? See again, patchy chronic inflammation, alveolar destruction, thickened blood vessels, big multinucleated giant cells. Can you see here in the interstitium and also in the interalveolar lumen with the cholesterol clefts? If you observe these things, it will be easy for you to diagnose this case. No, hot tub lung, it is usually you see very, it will not show that much of fibrosis, hot tub lung. Very ill-formed granulomas within the alveolar lumen. It is
Hypersensitivity pneumonitis.
Aspiration pneumonia.
Yes, that is a very good. What stage of hypersensitivity pneumonitis? Can you see this? Even
Advanced stage, sir. Honeycombing is present, sir.
correct. So whenever you see alveolar destruction, a lot of fibrosis, patchy chronic inflammation, it is almost going towards the end stage fibrotic lung disease. So here it is good enough we identified the giant cells. If you don't identify giant cells, you cannot. It is not possible for any pathologist when the disease is in the end stage, that is end stage fibrotic, diffuse fibrotic lung disease. It is not possible to say why the fibrosis, from where, what is the etiology of fibrosis in this lung disease. In this, we identified multinucleated giant cells, cholesterol clefts, and peribronchial inflammation that made us to think that it is a hypersensitivity pneumonitis. Even if you observe these cases, you do see Mason-like bodies, fibroblastic proliferation here, and there is fibroblastic proliferation here within the alveolar, pushing towards the inside the alveolar lumen. There is fibroblastic proliferation within the bronchial wall. If it is more, it occludes the bronchial lumen. Then we call it as bronchiolitis. Right? If the plug, it occludes the alveolar lumen, we do call it as organizing pneumonia. Okay, so all these features you can see when you have a chronic hypersensitivity pneumonitis. Your diagnosis one, right? And even if you see that, sometimes you see smooth muscle metaplasia also in the interstitium. That again indicates its chronicity of the lesion.
Sudhir,
Sir,
if you saw the fibrosis pushing the bronchial mucosa, no?
Yes,
If you find granulomas pushing the bronchial mucosa, think of hypersensitivity pneumonitis. That is one feature. Yeah, this is the
as and trichome stage, just to demonstrate the fibrosis. Can you see there is a distance between one alveoli and another alveoli is so much? Can you think of diffusion in this patient? No. So what would be the treatment of choice in this? If you see this kind of a biopsy, are there any medical line of management?
Lung transplantation.
Only the choice is lung transplantation, and actually it is a case of lung transplantation.
this is equivalent to cirrhosis of the lung.
Yes.
You cannot do anything. It's all fibrous. There's no way the airways can. This is the excised lung of the transplant.
Excised lung, the central part is unfixed. Can you see this? There is some cystic dilated structures, nodularity, there is uninvolved lung parenchyma in between, multi-lobar involvement, peribronchial location, all those features. Like, it is a case of hypersensitivity pneumonitis. He was a case of hypersensitivity pneumonitis. There's progress toward, yes.
Can we call it temporal heterogeneity in this, sir?
If you want to call, you can call in many cases, but certain terminologies have to be limited to a certain disease. You should not use those terminologies in other diseases. When the clinical setup and radiological setup is in case of either non-specific interstitial pneumonia or idiopathic interstitial pneumonia, then it's your duty to describe either temporal heterogeneity or spatial heterogeneity. Okay, those terminologies better to keep restricted to certain diseases. Okay, although it might meaning may be the same, but you should not use in case of hypersensitivity pneumonitis. One thing again I would like to highlight is in chronic hypersensitivity pneumonitis, even you do see NSIP features, you do see focal areas of UIP features, idiopathic interstitial pneumonia, you do see bronchiolitis obliterans, or organizing pneumonia, all type of patterns you may see in end-stage lung diseases, right? That is a good question. Yes.
Can I say something about it?
Yes, yes, sir.
Yeah. How we, if only the biopsies has come and no radiological features, the importance of the localized bronchiectasis and the same changes that you're showing, is there are much more things that we can dissect it out how to differentiate. Localized bronchiectasis, because the tissue will have the same way of reaction.
So, yes, yeah, definitely. So this has to be, as I told, the localized bronchiectasis, most commonly it will have some kind of an obstructive etiology. Obstructive etiology, they do undergo this patient, they do undergo bronchoscopic examinations, and if not possible, they'll dissect that part of the lobe. So there, predominantly the bronchioles wall shows dense inflammation with dilated, irreversible dilated mucus plugs involved. But here, the alveoli, they're also distorted predominantly. The bronchial, there is peribronchial inflammation, but bronchial walls are not showing that features of necrotizing inflammation of the wall. But on the contrary, in late diseases, they may also have bronchiectasis.
Secondary.
Yes.
So this is case number 7. I'll repeat. 42-year-old female presented with a history of headache, dizziness, weakness, pain in the upper limbs. Okay. Clinical examination revealed weak radial pulse, section from the thoracic aorta. I'll just go.
Sudhir, you can go.
Yes, I'll just move. Okay. So can anyone describe what is this? Is the wall, aortic wall, right? I'll just tell you the findings. See, if you observe, do you think the aortic wall is healthy? Gokul?
Can you repeat the question, sir?
By looking at the first section, it shows that it is section from the aorta wall, aortic wall.
Yes.
By looking at this, do you think the aortic wall is healthy or
No, sir.
normal?
Sir, it's more of fibrosis, sir.
Yes, there is a lot of fibrosis. Anywhere in the body, many vessels, they will have always, if they are not involved, they will maintain the contour. Can you see this? There is irregularity in the wall. Can you see this? And there is a lot of fibrosis. There is fibrosis. If you see the second picture, can you see this is the adventitial aspect? This whole thickness is the media. And if you divide the media, this part is not showing any nucleus. Right?
Yes, sir.
Here towards the adventitia, you have smooth muscle nucleus. There is smooth muscle nuclei loss. Okay, that picture indicates there is severe smooth muscle nuclei loss. Smooth muscles are destroyed in this area. Okay, if you see the next slide, again there is the adventitia.
So in the first one, okay, in the second one also.
Yes, yes. And if you see this third, can you see normally in the media, if you see the medial smooth muscle cells are very well oriented, very well oriented. They're properly arranged. The nucleus will be parallel to the lumen always. And if you see this, what is happening? Do you think the nucleus is parallel to the lumen or they are haphazardly arranged?
Haphazard.
Yes. So whenever you see this kind of haphazardness in the vessel, we call it as
Elastomer.
smooth muscle disarray, disorganized arrangement of smooth muscles. We saw irregularity in the wall. We saw nucleus loss, smooth muscle nuclei loss. We saw smooth muscle nuclei disarray. So whenever these things happens, the wall will become weak. The normal structure of the aorta will be distorted, and because of this weak arrangement, the wall will become weak. Why the wall has become weak? If you see more sections, can you see there are some patchy chronic inflammation, right? Can you see it here?
Yes,
Where
sir.
is the inflammation located? It is in the vessel wall or outside the vessel wall.
The outer part of the media, sir.
But the primary structure involved is the media.
Yes, sir.
If you want to, earlier also, previously there was a question raised by the resident. Whenever the inflammation predominantly involves the vessel wall, then only you call it as vasculitis, primary or true vasculitis. If the vessel wall is involved by secondary inflammation, there is an cellulitis, adjacent vessel is involved as a process because of cellulitis, don't call it as vasculitis. You should not mention in your report also, right? So when the vessel wall is primarily involved because of inflammation, then you call it as vasculitis. Now, Agam, tell me, is it a primary inflammatory disease of the vessel wall or not? This is the entire media. There is inflammation here. There is inflammation. There is inflammation. Inflammation. Adventitia looks fine. Fat is looks fine. There is a true inflammation of the vessel wall. Yes or no? Any doubt? Any question, doubts you can clarify. Inflammation is limited to the vessel media or not?
Yes, sir.
So it is a vasculitis.
Yes, sir.
Understood? Vasculitis. And rest of all secondary changes, what you're seeing, medial smooth muscle loss, smooth muscle disarray, areas of fibrosis, they all can be explained because of secondary inflammation, causing destruction of all these features. And
Yes.
one more important, if you see the adventitial blood vessels, no, usually it will not be that much thick. So whenever you see thick adventitial blood vessels, that indirectly states that the process is a chronic disease. Now tell me, it is an acute or chronic disease? Because I'm saying thick wall blood vessels, it is a chronic disease infecting the major wall. If you see this, if you observe, there is an inflammation here, small nest of inflammation. This inflammation, they are very much close to the adventitia, but they are within the media. Within the media, they are also there, but predominantly located in the outer 1/3 of the media, which is close to the adventitia, right? What structures do you expect at this location? Which supplies? Which vasoram. So this inflammation, if you observe, there will be small vessels inside in between this inflammation. So perivascular inflammation. And see this fourth area, the whole area is totally replaced by fibrosis and it is hyalinized. And you will see small areas of speckled dystrophic calcification as a degenerative process. If you see observe the periphery of this collagen, you have inflammatory cells, you have granulomas, you have multinucleated giant cells, epithelial histiocytes. Can you see at this magnification? All are there at the periphery of this degeneration. Can you see this? They are appearing as if they are preventing the process. Right? They are there at the edges. I'll show you a few other pictures. Can you see this big inflammatory infiltrate towards the adventitia? There is a blood vessel here. Right? See this blood vessel? And see this whole entire thickness of the aorta is totally damaged. No smooth muscle cells. It's just like national highway of fibrosis. Right? Only fibrosis. Here you have seen some kind of foamy cell aggregates that indicates atherosclerosis, and there is a lot of inflammation. If you see this inflammation in high power, majority of this inflammation of plasma cells, can you see this collagen degeneration in the wall? And observe all those histiocytes and epithelial histiocytes, they are guarding this collagen degeneration. They have come to clear up this collagen degeneration. Can you see this? All the histiocytes?
So this area, we see it looks almost like a rheumatoid nodule.
Yes, correct.
Because there's collagen degeneration with those almost cells palisading. It looks like that.
So this is
remember.
Yes, this is rheumatoid. You explained the similar like appearance. Collagen degeneration in the center, surrounded by histiocytes at the periphery. You may see multinucleated giant cells also. Right? Now tell me, is it an infectious granuloma or non-infectious granuloma? By looking at this appearance and morphology.
Non-infectious.
Yes, it is a non-infectious granuloma. Infectious granuloma shows more of a necrosis, neutrophilic infiltration.
Separation.
So yes, separation. And there are a few more pictures depicting or showing predominant plasma cell infiltration, severe wall destruction damaged by fibrosis, which altogether causing stenosis of the great vessel. When there is stenosis, the particular segment of the vessel, especially the major aorta, is involved. What will happen to the pulse?
So
It
weak
will,
pulse.
it will not transmit the pulse, systolic pulse. It will become more of a streamline. Hence, this patient had no pulse in the radial arm. So, when you see the classification of vasculitis, where do you classify this?
So large vessel vasculitis.
It is a large vessel vasculitis. What are the examples of large vessel vasculitis?
Takayasu and giant cell arteritis.
Takayasu and giant cell arteritis. Both are almost same with same etiological features. Okay. There is an age criteria.
Yes, sir.
Can involve,
So it's a dicey age actually.
correct. Yes,
All the criteria for Takayasu is less than 40, and for giant cell it's more than 50. So there's 42 lies in between.
So, thing is, giant cell arteritis most commonly affect the temporal artery, less commonly the major blood vessels. Takayasu more commonly affects the major. That you should take.
You see, many years ago, the same thing, no, vasa vasarum being infiltrated, narrowed, causing ischemia as well as this inflammation, used to be seen in syphilis. But we don't see them nowadays. So that differential is almost out now. So it is mainly two.
Yes, sir.
Okay.
Because ultimately you may have a dystrophic calcification. So you do see calcific deposits on the degenerated area. This is amorphous calcification deposition. Because it is an inflammatory process, you may have evidence of increased atherosclerotic changes in these patients. Again, atherosclerosis is again a chronic inflammatory disease of the blood vessels, larger blood vessels. So any inflammation can also enhance the atherosclerotic process. So you may see, I also showed in previous slides, you may have subintimal atherosclerotic changes in these individuals. But this is a mass and trichome stain just to demonstrate. Can you see this?
Fibrosis.
And these are inflammatory cells, they are surrounding this fibrotic area, and you have plasma cells here. Okay, this is perhaps Van stain. Yes, elastin stain. Can you see this? Media will have, these are called elastic arteries, you know. When you do
Elastophagia.
yes, these are elastic. Some of the remnant elastic fibers are left here, but here the total elastic tissue is totally gone, replaced by fibrosis.
In fact, aorta is an elastic artery. You know?
Yes, sir.
A lot of elastic tissue. This all one.
This is elastic tissue. So all this leads to weakening of the vessel wall. So you may have aortic, luminal narrowing, and also aneurysmal dilatation. Okay, again, few more pictures. Can you see? This is maintained medial elastic fibers, and the inflammation is there at the periphery. The part of the elastic structure is maintained, but here it's totally lost. So even see this.
The mucin.
Mucin stain. Mucin deposition. It also aggravates mucin deposition. It is present of mucin in the lamella. This is one lamella. Okay, can you see this wavy nature of the elastic fiber here? One smooth muscle, and in between you have mucin deposition. This we call as intralamellar type of mucin deposition. Is one of the components when you are describing medial degeneration or degenerative aortopathies. Okay, that will take up some other time when we have next seminar, the aortopathies.
You know the aortopathies like Marfan's and others, where you have a lot of medial degeneration.
Okay. This mucin is basically mesenchymal mucin, so not to differentiate
Yes,
the
yes,
epithelial.
sir. Yeah, that's a very
chondritis
yes.
sulfate, heparan sulfate, and
Yes,
those Hardler disease, mixopolysaccharides, and many other things. That
correct.
yes, very good. Yes.
So this is the case of Takayasu arteritis. All of you can identify Takayasu arteritis if you get a specimen.
Yes, sir.
Yes.
So IHC is not necessary for diagnosis, but for you to understand, you may have T cells. These are B cells, CD20 positive B cells. They have CD138, predominantly plasma cells, and few dispersed B cells. And you have T cells also, CD3 positive T cells.
Is there any other name for this Takayasu arteritis?
Pulseless disease. Pulseless disease.
What is aorta arteritis?
Aorta arteritis.
Takayasu.
Non-specific aorta arteritis.
Non-specific aorta.
We have to exclude, although in tuberculosis endemic countries like India, it's our duty to exclude the possibility of tuberculosis. Right? The most common cause of inflammatory aortitis
is tuberculosis.
Tuberculosis, where there is para-aortic lymph nodes, that tubercular lymph nodes, they will undergo caseous necrosis, they will rupture, and the inflammation spreads to the adventitia of the blood vessels, major blood vessels, causing it to aneurysmal dilatations. That is the cause, one of the important cause. All of you should know and try to exclude before you label it as non-specific aorta arteritis. Right? Last case, a young severely immunocompromised male. I will not show this. Can anyone describe this fast?
So this is a necrotizing large granuloma.
Yes, it is a large necrotizing epithelial cell granuloma. You say confluent granuloma.
Yes,
right?
sir.
There are
So complete effacement of the lymph node architecture, sir.
yes, entire lymph node is involved. Large areas of necrosis. What do you think?
Sir, fungal pathology.
Why not tuberculosis?
Sir, because sir, it's the immunocompromised.
No, that's what I skipped.
No,
I skipped the slide.
immunocompromised can get tuberculosis.
Tuberculosis is endemic countries like India.
So they go to the next power.
See this. Okay.
No, as you see, this looks almost not exactly caseous, you know, somewhat coagulative, like that it looks. You see, somewhat, you see, you can get the outline of some cells. Sometimes in fungal, especially those fungi which have a propensity for entering the blood vessels, like pheohypomycosis, some aspergillus, you can get with caseation some coagulation like necrosis. See, the ghost outline of cells are being seen. So that is another pointer. If you find neutrophils, that is another point. But good, what Sudhir said now, you cannot rule out tuberculosis outright like that. Okay.
Even in immunocompromised, TB is again the most common thing.
Yes, sir.
But of course, if you have seen some organisms.
Unless
Yes, sir. That's why I saw the next slide.
What did you see in this?
Yeast like organisms which are marked variation in their size, sir.
Very good.
And
There's another slide, no? Next, Sudhir.
Yeah, next. See this?
Okay.
Can you see this?
yes, sir.
This
Sir,
is
pseudo
yes.
the budding is present, sir,
Budding is present.
with a broad-based.
Branching is present. Right? Budding is present. Branching is present. And what is this? whether these fungus
So
have,
ingested RBC.
they have some color to it. How many fungal structures you have seen? On H&D, most of the fungus they'll have eosinophilic like structures, But what are these structures? Which color are these?
Brownish.
So whenever you see brownish color in the fungi, that is called as
Chromosomal.
pigmented fungus.
Pigmented fungus.
Dimethyl,
So,
okay.
the pigmented fungus, you have to identify, try to classify. Okay, at least pigmented and non-pigmented fungus we can see on H&D. So when you have pigmented fungus, if you see on H&D, you need not have to do special stains for demonstration. Not required also. Because pigment itself is very beautifully seen. You can identify the fungal hyphae. So what species is it? Only you can do by specific culture methods, right?
Okay, the two ladies, no, they're silent. So when you find fungus, what are the things you have to look for? Let the ladies say. Rashmi and who?
Right.
What are the things you have to look in the fungus?
Whether there's an intracellular or
No, let the two girls talk. No, they have not even opened their mouth, other than two cases. Yeah, Rashmi.
In which form they are, whether yeast form or hyphal form.
Correct. You have to first tell whether they are yeast-like, rounded, or hyphal form. Suppose they are yeast-like. What will you see? If they are yeast-like, one thing is you look at their size. Depending on the size, you can exclude the candidal species from the other species. Candidal species are small in size. Then you see whether there's a capsule or not, right? And then depending on that, you can find histoplasma and cryptococci, depending on that, right? If there is both yeast form as well as hyphal form together, then it's more likely to be, depending on the size, could be candida, because in that you will get like almost this, although they are pseudoid. So when you find a hyphal form of fungi, you have to see whether they are broad, whether they are narrow, whether they have parallel walls, whether they have septa, and whether they are branching and at what angles. So if they are non-parallel walls, okay, and septate, they're more likely to be zygomyces of pheohyphomycosis. Then if they are parallel walls with regular septae and then they're branching in a particular pattern, they're aspergillate. Then in that the others, you find whether they're pigmented or not. Okay, pigment will help you in telling what kind of fungi they are and so on. So this is basically how you go about doing the fungus. So in this case, what have you thought of? Who was describing?
Ashmi?
Or
Here in this,
Rantika?
we are seeing the budding yeast forms, and also there is a
I'll show you
the
special
branching.
things. One second. I'll show you special things. Okay, tell me.
Here,
Can you see the
budding,
budding?
yes, budding yeast forms are seen, and also branching is seen. A broad base.
They are pigmented.
That we saw in H&D, no?
H&D one. What is your diagnosis? So for your residents' sake, when you see a pigmented fungus, you should be able to differentiate whether it is there are two most important things. One is pheohyphomycosis and chromoblastomycosis, pigmented fungus. Most commonly we do see these fungus, right? Pheohyphomycosis, they are pigmented fungus which show septation and branching, hyphal form, right? And chromoblastomycosis, what do you call the other name? Appearance or structure?
Copper penny body.
Copper penny body. They are non-branching pigmented fungus. So if you know this at this resident level, that's sufficient. Okay. Now you'll differentiate chromoblastomycosis, no branching, no hyphae. It is no branching, pigmented, copper penny-like structures. Pheohyphomycosis, they are pigmented, branching, septate hyphae. Right. So this case, we have severe immunodeficiency. This is disseminated fungal infection, pheohyphomycosis. Okay, this is important because see this patient. Why I tell you 3-4 cases. This patient is presented with big blast on his eyelid, forehead, and skin biopsy shows a diffuse pandermal dense inflammation. From here till here, continuous diffuse inflammation. If you see at a hypo, predominantly lymphoplasmacytic, can you see plasmacytic infiltration along with vague ill-formed granulomas, interspersed histiocytic aggregates. So when you see this kind of inflammation, where in skin biopsy lymphoplasmacytic cells are very predominantly diffuse infiltration with tiny ill-formed granuloma, always if the patient is from UP, Bihar, or Rajasthan area, it is you have to search for LD bodies, cutaneous leishmaniasis. Right? This so accompanied cells and clinical things is also very, very important for your diagnosis. You have to search for LD bodies. If it is pure cutaneous leishmaniasis, I agree. Even after doing special stains, demonstrating LD bodies is very difficult. Very difficult. You may not see at all. So you need to have proper clinical and pathological correlation in these patients. Right? What is this? One more skin biopsy, and what are you seeing it here? There are histiocytes, granuloma. Then what are these structures?
Fungus.
Which fungus?
Histoplasmosis.
Why do you say it is histoplasma?
Sir, small round with a clearing of the. So perinuclear, it's a clearing around the yeast forms.
Clearing. And how do you say
Similar in size.
How do you say these are small?
Sir, smaller than the lymphocytes.
Adjacent cells you should compare.
Lymphocytes.
Lymphocytes, if you compare, where they are located. This is the histiocytic nucleus. Where they are located. This is the histiocytic nucleus where these
In the cytoplasm, sir.
predominantly intracellular. So your diagnosis is
Histoplasm.
So you have this histoplasma. If you see, they can also have granulomatous reaction. Histiocyte, can you see epithelial histiocytes?
Yes, sir.
The left side, yeah.
So one thing you should remember: these histoplasma, clinically, radiologically, they classically look like tuberculosis. Sometimes it is not possible to differentiate histoplasma tuberculosis. That time comes the importance of pathologists. If you identify these organisms, then the diagnosis will be solved.
So this, when we were residents, one of our teachers who was from states, he used to tell that tuberculosis in Kansas City is histoplasmosis. It's almost same. They get almost similar features.
Okay, so identification is very important. Yes, sir. I agree, sir.
Next
slide again. Spot diagnosis.
Very good.
It can also elicit giant cell reaction and granulomatous reaction, right?
If the sporules open into the interstitium.
Yes, see this, these granulomas, they're almost how they're eating up this sporangiospores. See this, it is sporangia is ruptured and already the defense mechanism is already there to prevent the engulf and prevent its spread. Can you see the histiocytes how they are well?
Acha, other than the nose, where else can you get rhinosporidiosis?
Lungs,
Lungs.
sinus.
Okay, respiratory tract, you leave. Anyway, you get in the urethra.
Sorry, sir.
Urethra. It comes from
Urethra.
water, no? Mostly, yeah, okay. Next.
Diagnosis. Sir already mentioned this. Big cells.
Cryptococcus proton giant cell.
Okay.
Proton giant. Good.
Okay, supposing you don't have mucicarmine or PS, can you do anything for cryptococcus?
Yes, sir. So we can do melanin, fontanamessins for.
No stain is available. Special stain.
No stain.
Special stain.
Sir.
The picture is not there. I should have put.
I forgot to put.
Someone is writing India ink. That is
No. What you can do is no stains.
No stains.
Then what you have to do is you have to polarize it. You get a Maltese cross. This one in cryptococcus. That's another thing you can do. Ajay, somebody has written that you can get rhinosporidiosis in bone and soft tissue. Yes, you can get. You can get. Definitely you can get. Those are not very common. Next.
Diagnosis.
Very good. So now you know what, if it is necrotizing or non-necrotizing granuloma, please remember that you must send the tissue for culture and other things. You know, for example, how many fungi can affect human beings? Any idea?
Sorry, sir.
How many fungi are known to affect human beings? Any idea? How many species total? You know, it's believed around 10,000 are there. But as pathologists, we know only 5. Yeast, that is Candida, then pneumomycosis, then we know about cryptococcosis, histoplasmosis, pheohyphomycosis, aspergillosis. Around these 6 we play, whatever it is. But actually there are nearly 10,000. It's always involved the microbiology, mycologists. Even in for, like they said, no, for tuberculosis, send it for culture, send it for. That is one thing you must do. Then you can do special stains. Then if you still don't search the slides again, sometimes AFB, some people see for 5 minutes, if you search for 10 minutes, you will get, or do more staining and other things. Then you search for blood vessels, other things, do additional studies. Still, there will be some proportion of granulomas we will not be able to diagnose. So we just leave them as it is. We combine the clinical pathological correlation and then do. Can you just press enter, Sudhir? Okay. You see, I read long time back that there are 3 things. Either we see the cause for the granuloma. For example, you are seeing a foreign body, you are seeing the fungus, you are seeing an AFB on special stain. So that is one group you can make the diagnosis, which is etiological. Second is you know the cause. For example, this is a known case of Crohn's disease or sarcoid. You have seen the biopsy. You know this is that lesion only. For example, sarcoid is mainly by exclusion. No AFB, no other organism. The ACE levels are raised. The X-rays are suggestive. Nothing alone helps. So then those are the second set of diseases in which the granulomas you know the cause. Like in caseous necrosis, there's no AFB, but even then you know this is tuberculosis. So that is the second set of disease. The third is you do not know the cause. So those are the granulomas that always cause a lot of problems. And it's believed is almost 1/3 of the cases, sometimes 10-20%, depending on the institution, where you get more difficult cases and all. You may not be able to make a histological diagnosis. But at least if you tell that this is this type of granuloma, necrotizing, non-necrotizing, and so on and so forth, at least it will help in narrowing down the differential diagnosis. And they'll give some empirical trick. So this is what
they were termed group 1, group 2, and group 3, sir.
You see, there are a lot of things, group 1, group 2, group 3, and then which people have described in the granulomas. But you know, for a practical purpose, often many institutions they don't follow that. So that is why we have not gone into all those details. Today we have tried, in many cases we have to rush up. We have tried to give you an overview of the different types of granulomas and some of the diseases. So we hope you'll go back, read, and then use this to build up your knowledge. I'm sorry it's gone very late, and dinner many of you may have missed in the mess or whatever it is. But I hope something you have learned. And Sudhir, I'm thankful to Sudhir for all the help and hope everybody has learned something. Dr. Saran,
yes, sir.
This is for you. Anything?
It was very elaborate, very lengthy, and in depth about all the aspects of granuloma. And I'm very thankful to Dr. Gupta and Dr. Sudhir, both of you, for giving such a vast experience and nicely dissecting each and everything. And very good participation by the residents.
Yeah, my claps to the residents.
Yes, so it was slow and very good. Only the point that we have exceeded some point. There's one thing which I wanted to just complete it. Can sir elaborate about the suppurative granuloma? And the suppurative granuloma, and when the necrosis is out of proportion than inflammation, when the giant cells are irregular in distribution, how this resident should approach?
See, most of the suppurative granulomas are because of infections. Most, you can be quite assured. Some suppurative, lot of neutrophils you can get in conditions like Wegener's and others, but those are rare. So first thing is, when you see suppurative, think of an inflammatory condition, infection, and then you do whatever you want and try to search for the organism. Fungi are first, and then of course sometimes you get the other lesions you can. And thankful he has drawn this.
So, so thank you both of them once again, Dr. Sudhir and Dr. Gupta. And on behalf of Dr. Sumit Gujral and Dr. Burgess, I have a opportunity to close the session. Thank you for the patience and understanding.
Thank you
so much.
Thank you very much, Sudhir and everyone.
Thank you very much.
Please return back.